Hello friends, I am Dr. Deepali Gupta, your Pediatrics faculty at Allen Next. So as a part of Guess the Paper series, today I am back again with the important questions which can be asked in your exam from the Pediatrics. Okay, so we are totally, just 22 days away from your exam. Anyways, let's gear up. Without wasting a single minute, let's start with the first question. Identify the organs or tissues whose growth curves are given below. So these are the growth curves which are very famously asked. You should be aware of them. What does A growth curve signify and what does the B growth curve signify? So as we can analyze in the A growth curve, most of the growth has already taken place, which we say almost 90% of the growth takes place by 2 years of age. So this on the x-axis, what you see is the age in years, and the y-axis depicts the growth, percentage growth of the organ. So which organ does it signify? The A curve, it signifies the growth of the brain. As we know that 70% of the brain growth occurs in the intrauterine period itself. So that means when the child is born, his 70% brain has already grown. And by 2 years of life, 90% of the brain growth has already taken place. So that is what the first curve signifies, and that signifies that it is the growth curve of the organ, that is brain. Now coming to the B growth curve, so here we can see the growth is continuously occurring over the years, and this signifies the growth of the somatic tissue. So which option will be correct? If we see, then this is the fourth option. Let us also analyze the other growth curves of the organs which are given in your book, in your standard textbooks. You should be aware of. First is the lymphoid growth. If you know, this is actually over here 100% and this is 200%. So in fact, in the age group of 4 to 8 years of age, the lymphoid tissue, it overshoots, it grows 200% in the age group of 4 to 8 years. Remember that. And that is why what question comes in your exam is that if the child, let us say a 6-year-old child comes to you for a regular body checkup without any complaints of fever or sore throat, and you see that the tonsils are massively enlarged, what are you going to do? Please understand, what are you going to do is do nothing. No intervention is required, because what you are seeing as enlarged tonsils is nothing but physiological hypertrophy of the tonsils, right? So that is what is seen between the age group of 4 to 8 years. So if a question comes like this, just look at the age and then you can go for the correct answer, right? Now, if we see this, the D curve, right? So this D curve, as you can see, it denotes gonadal growth. How will we come to know about it when it is asked in the exam? So you can see that the growth actually starts occurring around 12 years of age. So there's 12 years of age, there's a sharp increase, because that is the time when the pubertal spurt would take place and there's growth of the sex organs, or the gonadal growth would occur. So that is the biggest hint you can take and then answer the question correctly. So if tomorrow you have some different growth curves other than what two we have discussed, you can also answer that correctly. So let us move ahead with the next question. A child presents with short stature, his bone age is less than chronological age and growth velocity is normal. The height of his parents is normal. What is the diagnosis? Now here we are getting a very, very important clue. See, most of the time the clues are there in the question itself. So what is important clue over here is, first of all, it is a child with short stature right now, and his bone age is somewhat delayed than chronological age. And very importantly, the growth velocity is normal, which tells you that nothing serious is happening. No pathology is, currently occurring in this child. More or less, this denotes the growth velocity being normal. Still, he is of short stature. Probably denotes something to do with his normal physiology. That is the biggest clue you can get over here. And then again, the parent's height is normal. So in this case, my straight away answer would be, yes, you guessed it right. It is going to be constitutional growth delay. Now, somebody would ask, ma'am, why not familial short stature? See, in familial short stature, there are two things which are against familial short stature in the question. First of all, in familial short stature, the bone age is equal to chronological age, while in our question, the bone age was less than the chronological age. Another thing against familial short stature is, of course, as the name suggests, familial short stature means every member of the family, that means the parents of this child would be short. But here the height of the parents is normal. So that is against familial short stature. Cretinism and malnutrition, definitely these are not the options to be considered, because as we saw that the growth velocity is normal. There is no pathological process occurring in this child, and hence we would go either for A or B. B we have already explained that this cannot be the answer, so our answer comes out to be constitutional growth delay. Sometimes they would ask you, they might not supply you so much information, they might just give you one or the other graph, so you should know to identify which graph is which. So as far as your exam is concerned, please be very much updated and thorough about, one is constitutional growth delay, very important, and the other is familial short stature. So please be very careful about these two causes or etiologies of short stature, because this is one of the favorite topics to be asked in your exam. So what do we see here? You can see that bone age is indicated by the triangle, and you can very well see in the graph A, the bone age is definitely less than the chronological age. So if bone age is falling somewhat, let us say here, then the chronological age is over here, and we know on the left side the age is of the lesser value. So here in graph A, bone age is less than chronological age, while in graph B, if you can see, the bone age is almost coinciding with the chronological age. So then we know that probably the graph B would denote familial short stature, while the graph A would be going towards constitutional growth delay. Another very important clue which you can see and distinguish whether it's a graph of constitutional growth delay or familial short stature is, look at what is happening at the end of the graph. So if I have to denote, somewhat like over here. So here you can see the child is crossing the centiles, and actually his final height is within normal range. While in the other graph, if you see, over here, the child's final height still remains below the third centile. So this is the final height, if I may tell you. So this is the final height, right? And this is definitely below the third centile. It is not crossing any centiles. The final height is not within the normal range. The child eventually stays of short stature only. So that is again the biggest clue to distinguish whether this is familial short stature or constitutional growth delay, because in constitutional growth delay, the ultimate height is the final height is going to be normal, while in familial short stature, the final height is going to be short stature only, going to be less than the normal, right? So this is how you distinguish between these two graphs. Be very careful, very commonly asked question, and it has been repeated umpteen number of times in your previous years, right? Okay, so we should be very well aware of the differences between the familial short stature and constitutional growth delay. So let us quickly draw a table, telling us the differences between the constitutional growth delay and the familial short stature. So this is familial short stature over here, this is constitutional growth delay, and these are the features. So if we talk about the sex predilection, obviously the familial short stature would be both males and females are equally affected, depending on whether parents are short stature or not, and the cause is familial short stature. While constitutional growth delay is more or less seen more commonly in males than females. Remember that, right? Another difference between these two features is the length at birth. So this would not be any difference, because if you see, the length at birth in both the cases will be normal, and then in the coming 1 or 2 years of life, the child starts falling below the third centile and becomes of short stature, right? Another difference between these two would be depending on the timing of the puberty. So if you know, in familial short stature, the child is definitely the pubertal onset or the pubertal spurt will be not affected. That means the timing will be totally normal. It will come at normal time. But while in constitutional growth delay, what we get to see is delayed puberty. While the rest of the peer age group children, they are growing, they are, catching up their height. This child of ours remains of short stature, and that is what concerns the parents, right? Another, I would not say the difference because it is an important feature seen in both, and that is the growth velocity. Remember, the growth velocity is normal in both these cases. Though in the first 1 or 2 years of life, the growth velocity will definitely decrease, but once it comes below once the, the height comes below the third centile, then it grows totally, at normal interval, at normal pace. So the growth velocity in both familial short stature and constitutional growth delay is going to be normal, right? Then what about the bone age and chronological age? So we know in familial short stature, the bone age corresponds with the chronological age, while in constitutional growth delay, the bone age is definitely delayed as compared to chronological age, which is of relief. That means the child has the potential to catch up with the height, right? And finally, if we have to see the final height in familial short stature is going to be short, while in constant growth delay, it is going to be normal. We can also write, the height of the parents in the familial short stature. The height of the parents is going to be what? It is going to be definitely short, while in constant growth delay, the height of the parents is going to be normal. So these are the some important differences that will help you solve the MCQ in the exam, which you should be aware of, right? Let us move to the next question. During a pediatrics viva, student was given 4 statements, out of which he was asked to select the most appropriate one. Which of the following statements would have been chosen by him that the examiner was satisfied with the answer? So that means more or less, if we want, you can write the examiner is going to ask you which is going to be the true statement that will satisfy the examiner. So first statement is birth weight triples by 2 years of age. Does it? No. Does it triples by 2 years of age? So the birth weight is, around 3 kgs. If we take the birth weight to be 3 kgs, it triples by 1 year of age and not 2 years of age. So obviously the examiner would not be satisfied. The infant measures 90 centimeters at 1 year of age. So if we know at birth the child measures around 50 centimeters and 50% increase in the height occurs in the first year of life. So what is 50% of the 50 centimeters? We all know it is 25 centimeters. So add 25 centimeters to the 50 centimeters. And what comes at 1 year of age? The length to be 75 centimeters. So definitely it is not 90 centimeters. Again, the examiner is not satisfied, right? Then the head circumference becomes equal to the chest circumference by 6 months of age. No, it becomes equal by 1 year of age, not 6 months, right? We are going to revise all this in a short while. And then finally, for the first 3 months of life, weight gain occurs at a pace of roughly 20 to 40 grams per day. Yes, this is a totally correct statement, and that is what will satisfy the examiner, right? So this is the correct statement, and this is going to be our answer because they asked what is true in this child, right? Okay, now let us move to the next, rapid recap of the growth. How does it occur? How does the weight gain occur? We know that 10% weight loss occurs after birth. If we have to write the range for terms, it is 7 to 10% for term children, and for preterm, it is going to be 10 to 15%. Remember that, right? And then birth weight usually regains by day 10 of life in terms, and if somebody asks you about preterm, then it is by 10 to 15 days of life the birth weight is regained by a preterm. Then approximately, as we just saw, that is 20 to 40 grams per day increase in the first 3 months of life, and thereafter it is 400 gram per month for the remaining year, right? And then in the coming 3 to 7 years, it is 2 kg per year. Remember that. And then comes the pubertal growth spurt. Between the 7 years and the pubertal growth spurt, the weight gain is around 3 kg per year. So you should know these normal values. They can be asked in exam in any ways, right? Coming to the rate of weight gain, when does it double, when does it triple, as it was asked in this question. So you should be aware, the weight gain, the weight usually doubles by 5 months of age. Okay, the 5 months of age, if the child is born with a weight of 3 kgs, then the child will become 6 kgs by 5 months of age. It triples by 12 months of age. That means at 1 year of life. So that means the child will become around 9 kgs at 1 year of life. then it quadruples by 2 years of age. So that was the wrong statement. It was given in the question, it triples by 2 years of age. No, it quadruples by 2 years of age. That means if the child, if we take an average birth weight of 3 kgs, then it becomes 12 kgs at 2 years of age, right? Then it becomes 5 times by 3 years, and it becomes 6 times by 5 years, right? So that we should be knowing, and then it is very easy to remember. It becomes 7 times by 7 years and 10 times by 10 years. So you should know. Anyways, if you cannot remember this, bacha, do not worry. This is not important. What is important is the doubling, the tripling, and the quadrupling, and of course 7 years by 7, 7 times by 7 years of age, and 10 times by 10 years of age, right? Now let us see how does the height increase. So height, there is 50 centimeter at birth. So 75 centimeter, I told you, plus 25 to plus 25 centimeter means 50% of the original, original means the birth height rather than the original. So 50% of the birth height is gained in the first year of life. So it becomes 75 centimeters by 1 year of life, and then it becomes 90 centimeters by 2 years of life. Remember that. And then 95 centimeter at 3 years of life. And the most important thing is now coming, which you all need to remember, 100 centimeters at 4 years of life. So what question can come in exam is that when does the birth height or the birth length becomes double? So remember, birth length becomes double at 4 years of life. Remember that. Very, very important piece of information for your exam, right? And thereafter, the gain is around 6 centimeters per year. And of course, during the pubertal spurt, the height gain is almost double. That means around 10 to 12 centimeters per year during the period when the pubertal spurt is occurring, right? Now, coming to the head circumference, again, very important. This should be, as I always tell you, GKP. GKP मतलब खोट के पी जाओ. इस तो आपको याद होना चाहिए. There is no excuse that you should not be knowing this. So the, gain of the head circumference or the growth of the head circumference is in this fashion: 2 centimeters per month in the first 3 months, and then it becomes 1 centimeter per month in the next 3 months, that is from the 4 to 6 month of life, and then it becomes 0.5 centimeter per month in the remaining 6 months of the first year. So if we start at 35 centimeter at birth, and if you calculate all this, this comes to be a gain of around 12 centimeters in the first. So 12 centimeters in the first year of life. That is the gain, and no wonder at 1 year the head circumference becomes 47 centimeters. Very, very clear about it. Then in the next year of life, you will be amazed to know in the second year of life, the gain is only and only plus 1 centimeter. Okay, in the next, let us say in the next 2 years of life, the gain is only 1 centimeters, or in the next 3 years of life, the gain is only and only 1 centimeter. So 47, if we write 47 centimeter at 1 year, you can very coolly write 48 at 2 years, 49 at 3 years, and 50 centimeters at 4 years, right? So that means another way of remembering is that the head circumference is almost 50% of the height what is attained at 4 years, because at 4 years the height attained is 100 centimeters. So this is the height I am talking about, and this is the head circumference what we are discussing right now. So almost 50% relation is there at 4 years of age, and then it becomes 52 centimeters by 12 years. Now coming to the relation between chest circumference and head circumference. So chest circumference is definitely less than the head circumference by 3 centimeters at birth. And then, as I was telling you, that was there in the question, that at 1 year of age, remember, chest circumference becomes equal to the head circumference, and thereafter always remember, chest circumference surpasses head circumference, although by a few centimeters, but yes, it surpasses head circumference, right? So that is it about growth. This much you should be very clear, and I'm sure you're going to get 1 or 2 questions and you're going to ace them, right? Let us move forward. Cruising around furniture is seen earliest at which age? Yes, we must be knowing that when the child, moves with the help of taking the support of the furniture or somebody around, that is known as cruising around furniture, which is shown in the diagram. The correct answer over here is 10 months of age. So that is the correct answer, right? Okay, then coming to the next developmental milestone, age of achieving this milestone is. So what is this child doing? This child is turning, is pivoting. Pivoting means turning around, keeping the gluteal region as a base, and is twisting his upper body on his gluteal region, which is known as pivoting. And pivoting, remember, also occurs at 10 months of age. So 10 months of age is actually very significant. In the first year of life, you have many milestones the child is going to gain at 10 months of age. One is cruising, one is pivoting, which we have just seen. Then the child, is, what is the child doing? He's drinking by the cup, and in the next figure you can see the child is handling a spoon. How do we remember when does this come? So drinking by a cup comes at 15 months of age, remember this. And handling a spoon, how do you remember? I remember it like this. So two, we know spoon has two O's, two golas, and 18 months also has two golas, right? So 18 months, right? So 18 months has two golas, and spoon also has two golas. So remember, handling of spoon comes by 18 months of age. Then let us come to the next milestone. Important milestones only we are discussing, guys, so that you can remember them. You can concisely put it in your memory, right? Independent walking is seen earliest at what age? So that independent walking is 15 months. This child is of 15 months walking independently. By 12 months is nothing but 1 year. The child walks with one hand held. Always remember this. I always tell my students a story. On his first birthday, on her or his first birthday, the mother would hold one hand of the child and take the child to the table where the cake has been set for him, so that he or she can cut the cake and enjoy his moment. So remember, one hand held. The child has to hold the hand of the mother and walk to the table. So at 1 year of age, walks with one hand held. Independent walking comes at 15 months of age, right? Okay, then we should know some language milestones very commonly asked. So monosyllables, at what time do they come? Yes, they come around 6 months of age. Bisyllables come at around 9 months of age. 1 to 2 words with meaning would come around 1 year of age. 8 to 10 words would come around 18 months of age. How do you remember 18 months? See, this is 8 over here and there is 8 over here. So 8 to 10 words would come around 18 months of age. Now 2 to 3 word sentences. Over here we have to make some distinction. So 2 to 3 word sentences and the usage of pronouns comes around 2 years of age. Remember, 2 to 3 words sentences, not 2 to 3 words only. A sentence made up of 2 to 3 words comes around 2 years of age, while at 2 years of age, the vocabulary increases greatly to 100 words. They can simply ask you, vocabulary of 100 words is seen at what age? Remember, 2 years, 2 years, 2 years. Imagine in the second year of life, the child gains so much. At 1 year, he's just having the vocabulary of 1 to 2 words with meaning, while at the age of 2 years, the child is having a vocabulary of 100 words, and he can make a sentence of 2 to 3 words at 2 years of age. Now, asks questions, knows full name and even gender. So this comes at what age? Yes, you are correct. It comes at 3 years of age. Tell stories at 4 years of age. Later on also we will write what all he can do at 4 years. So there you will say he tells stories, he tells poems, that comes at 4 years of age. And ask the meaning of words at 5 years of age. Now what has come in your previous year examination? We need to revise that also. So handedness, remember, is established usually by 3 years of age completely. That means the child is going to be right-handed or left-handed. That is completely clear by 3 years of age. In certain books it is written it may come as early as 2 years of age, but usually gets established by 3 years of age. So we will consider 3 years as the time when the handedness will get established, right? Okay, then let us do one question. A mother suspects a developmental delay in a 3-year-old child. So she brings her to a pediatrician. The pediatrician assures her that the child is not lagging in any milestone. Which milestone in the following options was present in this child which assured the pediatrician? Okay, so the child is going to the toilet alone, saying songs or poems, telling stories, sharing toys, knowing full name and gender. Okay, one D option is missing. So let me write a D option for you. The child can child is not able to draw a triangle. So, which milestone which was the pediatrician was present in this child, which assured the pediatrician that this child is actually of 3 years of age and not a point of concern at all. So, what is this? Yes, you are correct. The correct answer is going to be the child shares toys, knows full name and gender. See, in certain books, you may find sharing toys coming at 4 years of age. But look at other things also. Over here, the child is knowing his full name, knowing his gender. That usually comes at 3 years of age. So that is how the pediatrician is going to assure the mother that nothing is wrong with the child. Even if he cannot draw a triangle, the triangle drawing comes at what years? Yes, it comes at 5 years of age. So therefore, we are not concerned if the 3-year-old child cannot draw a triangle, because anyways that he will achieve at 5 years of age. Saying songs or poems, telling stories, this all comes at 4 years of age. Going to the toilet alone again comes at 4 years of age. So what is age appropriate in this child is the option C, and that is going to be the correct answer over here, right? Now coming to the fine motor dressing, which we should know that the child is able to pull off socks or mittens by 1 year, unzips by 18 months. Always remember, the child would first learn to un means undress, unzip, and then zip himself up or dress himself up. So undressing comes by 2 years, and then putting on shoes and socks comes at 2 years. So he was able to take off his socks or mittens at 1 year, but putting on comes at 2 years. Now he is able to undress himself at 2 years, while he will be able to dress himself by 3 years of age. And finally, the tying of shoelaces, very, very important from your examination point of view. Lots of questions. This is one clue that will be there in the question that will help you that decide whether the child is of 5 years of age or not. Tying shoelaces, and the other thing which comes for 5 years is can draw a triangle. Always remember that, bacha. If you are able to spot these two milestones in the question, then straight away go for the age of 5 years, right? Now another thing, child copies circle by what age? Yes, you are correct, 3 years of age. Cross also, please don't take cross as multiplication size. Cross means a plus sign over here. That comes at 4 years of age, and a triangle would come at 5 years of age. The child would be able to copy a triangle at 5 years of age, a cross at 4 years of age, that means a plus sign, and finally, a circle by 3 years of age. So at 4 years child, what all the child can do, that should be we should be aware of. He can sing a song, he can tell poem, ask questions, goes to the toilet alone, then button his clothes. Very importantly, see, buttoning does not come at 3 years. We just saw that 2 years the child learns to undress himself, important, right? At 3 years he learns to dress himself. At 4 years the child learns to button himself up. So button handling comes at 4 years, not before that, right? Then catches ball reliably again at 4 years, and as I told you, copies rectangle, cross or plus sign at 4 years. How do you remember? 4 is 4 corners, so 4 corners of rectangle he is able to draw at 4 years. For that matter, you can also say square, but square specifically they have written 4.5 years for a square, but does not matter. They are not going to ask you so much in detail, but you should know the 4-sided figures like a rectangle is drawn at 4 years of age, right? At 5 years, what all the child can do? He can tie shoelaces, he can help in household chores. Again, very important. Skip, very, very important, will help you solve many MCQs, right? Which comes for 5 years. Copies a triangle or a multiplication sign. So actually a multiplication sign comes at 5 years. Can follow 3-step commands, can compare 2 weights, and can distinguish between morning and evening. So that also comes at 5 years of age. So this is a list. Why I have given you a list for 3, 4 and 5 years, bacha? Because this is usually the hotbed for the questions which arise for these years. So you should be very well aware what all the child can do at 3 years, 4 years and 5 years. 3 years we discussed in form of a question, and then 4 years and 5 years we have already discussed, right? Okay, then let us come to the next question. Which of the following milestone is not seen at 1 year? Stands without support, can speak, mama, papa, plays peekaboo, draws parallel lines. So we know this, the child can stand without support, can speak mama, papa, because these are bisyllables that would come, at 9 months of age itself, can play peekaboo, even that comes at around 8 to 9 months of age, and draws parallel lines. Remember, draws parallel lines, there are 2 lines to be drawn, and that comes at 2 years of age. Always remember the parallel lines, or for that matter, line is a geometrical figure with 2 ends. So that is how you have to remember, that will come at 2 years of age, not at 1 year of age. So our correct answer is going to be the D option. So D option is correct over here. Then, so this is how we are going to remember. So at 1 year of age, the child can scribble, right? At 2 years of age, the child can draw 2 parallel lines that we have just discussed. At 3 years, circle. 4 years, plus sign. Let us cross it plus sign rather than a cross. So 4 years plus sign, 4.5 years comes the square, and then 5 years comes the triangle, and finally at 6 years the child can draw a 6-sided figure, or maybe even a diamond can be drawn at 6 years. So 6 years, if they ask, then diamond drawing, that comes at 6 years, right? Or a 6-sided figure. Okay, now let us move forward. So this is a child waving you bye-bye. What is the, appropriate age or probable age of this child? So most probably the child is 9 months of age, because waving bye-bye comes at 9 months of age. How do you remember? The child is given MR, or for that matter MMR, and then he waves bye-bye to you. Remember that. So that way you will remember this vaccine, MR vaccine and MMR vaccine, is given at 9 months of age. So in the public domain, I know MR is given, while in the private practice in our country, MMR is given, where the another M stands for mumps and MR stands for measles and rubella vaccine. So he would take the MR or the MMR vaccine and then wave bye-bye to you. No child is going to do that. I know that he'll be in pain, but anyways, that is how you remember, right? Now this child, tell me the age of this child. So let us count the cubes, 1, 2, 3, 4, 5, 6, 7, 8, 9. So 9, this child has very nicely, ably, constructed a tower of 9 cubes, and then you are being asked, what is the approximate age of this child? So how do we remember the cubes? So remember, at 15 months, the child can, construct a tower of 2 cubes. At 18 months, 3 cubes. And then very easy to remember, only these 2 you have to remember. 2 years and 3 years, you just multiply by 3 and you get your answer. So 6 cubes over here and 9 cubes over here. And we can see this child has, constructed a tower of 9 cubes. So my answer is going to be, the age of this child is, yes, you guessed it right, the child is of 3 years of age. So remember, 15 months, 2 cubes, 18 months, just add 1 more cube, that means 3 cubes, and 2 years and 3 years multiply by 3. So 2 into 3 is 6 cubes and 3 into 3 is 9 cubes, right? So you should know these, your cubes handling or tower constructing very well, because again, a hotbed of questions for you, right? Then what is the approximate age of this child? Tell me this. Yes, you are correct. The answer is 6 months. The child, watches his mirror image and smiles. So that comes at 6 months. Now this, let us assume, is a stranger. So with a stranger, the child is howling, is crying, is not happy. What do you call it? We call it stranger anxiety. And when does stranger anxiety come? It comes at around 6 to 7 months of age. So that you should remember, the approximate age or the probable age of this child is around 6 to 7 months. That is the earliest seen stranger anxiety. And very importantly, the grasp, how does it develop? So at 5 to 6 months, the child would be having a palmar grasp. So you can see he is using whole of his palm to catch the object of his interest. Like radial palmar grasp would come at around 6 to 7 months of age, and then at 9 months of age, he would start with his pincer grasp. Now that pincer grasp which is seen at 9 months of age is not a very clear or a clean pincer grasp, right? So that is why it is sometimes referred to as immature pincer grasp or an inferior pincer grasp, wherein the child is not using the tips of his index finger and his thumb, but the side portion of his fingers and thumb. So this will be known as inferior pincer grasp or the immature pincer grasp, that begins at around 8 to 9 months of age. More appropriately, you would say 9 months of age, right? And then fully developed pincer grasp, where he would neatly, pick up a raisin or a very small, dana of, let us say, a rye or a mustard. Very cleanly he would pick up using the tip of his index and thumb finger, which is known as the mature pincer grasp. So that comes at around 12 months of age. So mature pincer grasp is seen at 12 months of age. So that you should be very, very clear with, very commonly asked in your exam, right? Now tell me the next question, answer to this question: which of the following appears first in the child? Creeping, crawling, mirror play, or the pincer grasp? So see, creeping and crawling. So we are very much confused. Creeping किसे कहते हैं, crawling किसे कहते हैं? Always remember, the snakes, they crawl and the cats, they creep, right? And crawling, A comes before E. So snakes crawl, that means crawling would come at 8 months and the creeping would come at 10 months. Creeping is nothing but the child, walking or, crawling on all his fours with abdomen off the ground, That is what is known as creeping. It is not called crawling. Always remember, the children, they get confused between creeping and crawling. So this is cats, the way the cats move, that is known as creeping, while the snakes would crawl. So that comes at 8 months and the creeping would come at 10 months. Mirror play, we just saw the child is smiling at his mirror image, that comes at 6 months. And pincer grasp would come between 9 to 12 months. Since they have not mentioned whether they are asking about mature or immature, we would just say 9 to 12 months. Now we have to decide which appears first. So we can very clearly see what appears first in this child is the mirror play. This is going to be your correct answer for this question, right? So let us again see what is crawling and creeping. So this is what I was saying. This is snake crawling, right? And this is cats creeping. So that is what comes at 8 and 10 months respectively, right? Okay, then let us move forward. The red flag signs, very, very important, which we all need to know, because that is how, you can be judged. You can be asked about the upper limit of a particular milestone, which you should be aware of. So very, easy ones I would do first. So, scribbling usually begins at 1 year of age. We just saw that figure of 1, 2, 3, 4, where at 1 year they had shown something like 1 and then there was a scribbling like this. So scribbling begins at 1 year of age. So if it does not appear by 2 years of age, it's a red flag sign. Pincer grasp usually begins by 9 months of age. If it has not appeared by 12 months of age, it's a red flag sign, right? Sitting with support usually comes at around 5 or 6 months of age. If it has not come by 9 months, it is a red flag sign. Standing with support usually comes at around 9 to 10 months of age. If it has not come by 12 months, it's a red flag sign. Walking with support comes at around, again, 10 to 11 months of age, sometimes 11 to 12, we can say walking with support with come. But if it does not come by 15 months, it's a red flag sign, because by 15 months, the child should be walking independently. But here the child is not being able to even walk with support. So that's a red flag sign. And walking without support, usually appears at 15 months. If it does not comes by 18 months, it's a red flag sign. So you should know these red flags very clearly. Vocalization usually begins by 2 months of age, does not come by 6 months, it's a red flag sign. Babbling usually comes at 4 to 5 or 6 months and then does not come by 12 months, it's a red flag sign. Single words usually come by 1 year of age. If they have not appeared by 16 months, it is a red flag sign. A very important milestone which everybody needs to remember, even in their deep sleep, is the appearance of social smile. Usually comes by 8 to 12 weeks of age. has not come by 6 months, it's a red flag sign, very commonly asked in your exam. Waving bye-bye usually comes by 9 months, but if the child is not waving bye-bye by 12 months, it's a red flag sign. So this you should be knowing the important milestones whose upper limit of normalcy has to be remembered, and so that you can answer the questions, right? So let us move forward. I think enough for the milestones. Let us move with the nutrition chapter. An 8-month-old child was found to have features of vitamin A deficiency. What is the dose of oral vitamin A which is required? So we should know that, different ages, and we all already aware of the dosages. So let us quickly recap. For less than 6 months, the dosage of oral vitamin A is 15,000 international units. For 6 to 12 months, it is 1 lakh international units, right? And for more than 12 months, it is 2 lakh international units. Remember, if the child is more than 12 months but less than 8 kg, still we will give only 1 lakh international units because of his less weight. So that caveat should also be remembered by us, right? And remember, when we are treating the vitamin A deficiency, 3 doses have to be given. When? At day 1, at day 2, and at day 28, right? Now, this was a 8-month-old child. So, if we go by our table, for a 8-month-old, what is the correct dosage? Yes, the correct dosage is going to be the C option. That is the 1 lakh international units have to be given. Now, one more thing which everybody has to remember is that if there is, important is clouding of cornea, I've noticed, then straight away one has to go for parenteral vitamin A, and the dose is 50,000 to 1 lakh units. So that is an emergency to be treated. If the clouding of cornea is noted, that means opacity has already developed on the cornea, then we have to go for, and if this is obviously, if this is an, feature of vitamin A deficiency, we can see clouding of cornea with some congenital problems also, or some, storage disorders like mucopolysaccharidosis. In that, we do not need to give that much, but only when we are suspecting vitamin A deficiency associated clouding of cornea, then one has to go for emergent treatment in form of 50,000 to 1 lakh vitamin A given parenterally, right? And one more important thing is that if you, give overdosage of of vitamin A, hypervitaminosis A results in pseudo tumor cerebri, where the child will exhibit signs of raised ICP without there being an organic lesion. So that is pseudotumor cerebri for you. You should remember this is very important side effect of vitamin A overdosage, right? Okay, now let us come back to our next question. Pearly white lesions with foamy appearance. Can you see this lovely foamy appearance? Not very lovely for the child, of course, but very nicely given over here with foamy appearance seen on the sclera of the child. Which of the following other symptoms are related to the deficiency of the same nutrient causing the mentioned lesion? We know these are nothing but Bitot spots, and Bitot spots we know they are caused by vitamin A deficiency. So what other than Bitot spots can vitamin A deficiency cause? Can it cause conjunctival xerosis? Of course, it can cause conjunctival xerosis. Can it cause angular stomatitis? Angular stomatitis is more a feature of B2 deficiency. Again, glossitis is more a feature of B2 deficiency. And a photosensitive rash, we all know, is a hallmark of pellagra or a niacin deficiency, right? Which we see in the form of castles or Casals necklace, right? Around the neck or in the areas which are exposed to sunlight, right? So here, since we are talking about vitamin A deficiency, so our correct answer is going to be conjunctival xerosis. So this is the way, the questions can be asked where the examiner is trying to test not only your knowledge about vitamin A, but for other vitamins also, so that you can very clearly, strike off other options. Okay, now the WHO classification, I am sure you must be totally, this should be totally, क्या कहते हैं वो, रट के घोट के पी जाओ, very important from all your PSM point of view and the pediatrics point of view. But a quick recap, we know there are primary signs and the secondary signs. The primary signs is X1A, 1B, and then we have X2 and then X3A, 3B. X1A starts with conjunctival xerosis, 1B. B stands for Bitot spots, then 2 is for corneal xerosis, and 3 and 3B would be dealing with corneal ulceration, where the ulceration is involving less less than 1/3 of the cornea, that would be X3A, and 3B would be where it is involving more than 1/3 of the cornea, right? And then we have the secondary signs where we have N, F, and S. XN stands for night blindness, F stands for fundal changes, and S stands for corneal scarring. So that you should be totally aware of. Treatment we have already discussed above vitamin A, right? Now, let us move to the other vitamin deficiency. Which nutrient deficiency can cause collagen defect? Yes, we know this. Umpteen number of times it has been asked. This is none other than your favorite vitamin, which we find in oranges, and that is your vitamin C, also known as ascorbic acid. We know that vitamin C is absolutely essential for the cross-linking of the fiber strands of collagen, for the addition of lysine and proline and making the collagen strong, because the collagen is a part and parcel of the connective tissue, and vitamin C is absolutely essential for all that purpose. If vitamin C is not there, there is instability or there is defective connective tissue, and that is why what we get to see is a subperiosteal hemorrhages would be there, perifollicular hemorrhages would be there, gum bleeding is there. So all these features would come with vitamin C deficiency, which we know by the name of scurvy, right? So collagen defect occurs because of vitamin C deficiency. Coming to the next question, again closely related to what we were just discussing. A 10-month-old child predominantly on milk-based diet, in which he is given, very importantly, boiled cow's milk daily, presents to you with irritability, anemia, bleeding gums, petechiae all over the body, and inability to move his lower limbs. What is the most likely diagnosis? So what are we dealing with? Is it scurvy, rickets, Keshan disease, or is it Menkes disease? What are we dealing with? So please remember, this is nothing but scurvy. What what tells us this is scurvy? Why not we go for rickets? See, he is being given a milk-based diet, importantly, and that also boiled cow's milk. You should know, anyways, the cow's milk vitamin C content is almost negligible, around 0.2 to 2 gram per 100 ml. Imagine. And that also, when we boil it, this milk vitamin C content becomes a big fat 0, because vitamin C is a heat sensitive vitamin. Anyways, boiled cow's milk has no vitamin C, and the child is not being given anything other than boiled milk. So that also cow's milk. So that is why he is prone to develop vitamin C deficiency. And we know vitamin C deficiency gives rise to subperiosteal hemorrhages, perifollicular hemorrhages, and gum bleeding gums. And of course, the irritability and anemia would be there. And why he is not able to move his limb is again because of the intense pain because of the subperiosteal hemorrhages. So that is why that you should know that scurvy is one of the differential diagnoses of pseudo-paralysis. Pseudo-paralysis means the child is not moving his limbs because of the pain, not because of some CNS disorders, but because of the pain. So if we have to, go for the causes of pseudo-paralysis, always remember certain, causes of pseudo-paralysis. First is your scurvy. Second is hypokalemia, very, very important, when the serum potassium levels are very low. And the third important cause, which everyone has to remember, is congenital syphilis. In syphilis also we get to see periostitis. Periostitis, we would see the X-ray pictures of periostitis, and then you would realize that that is also one of the cause where the newborn would be having pseudo-paralysis, would not be moving his limbs, right? So this is scurvy for you. Keshan disease, we are going to discuss, don't worry. And then Menkes disease also we are going to discuss in the coming slides. Okay, then these are the features of riboflavin deficiency. And we all know riboflavin deficiency is nothing but vitamin B2, all asked in your previous year as a question which has come in your previous year. So that is why I have put over here. So this is nothing but intensely red tongue. This is glossitis. Of course, if this kind of tongue comes with other features of unilateral cervical lymphnopathy and edema of the hands and feet, then your diagnosis should become what? Yes, Kawasaki disease, not this. But here, we are dealing with a non-vasculitic kind of thing. So here the diagnosis will become glossitis, and this is your angular cheilitis, So this is vitamin B2 deficiency. Very importantly, sometimes in the question they have not given glossitis and angular stomatitis. These two things have not been given. What has been given is the child is having photophobia, seborrheic dermatitis, typically around nasolabial folds, right? And corneal vascularization and the cataract, then what is your diagnosis? See, when the glossitis and cheilitis is not given and these features are given, then also you should be able to catch it. This is riboflavin deficiency. Very important, right? Now, non-specific symptoms of vitamin B2 deficiency includes anorexia, weight loss, weakness, dizziness, and confusion. Not very commonly asked. What you should remember are these two things: corneal vascularization and cataract, and of course the photophobia, right? So this is a quick recap of all the vitamin deficiencies we should be aware of. So we should know that in beriberi we have two kind of presentation. One is the heart involvement, where the child goes into congestive cardiac failure, or the neurological involvement in form of peripheral neuritis. Riboflavin deficiency, we've already discussed the mouth signs, the eye signs, the corneal vascularization and the cataract, and photophobia, and the skin seborrheic dermatitis, typically involving the nasolabial folds. Very importantly, what is asked in your exam is the niacin deficiency, also known as the B3 deficiency, where you get to see pellagra, which is consist of 3Ds: dermatitis and diarrhea and dementia. And here on the skin, in the exposed part of the skin which is exposed to sunlight, we get to see a photosensitive rash, which is seen in form of a necklace around the neck and is known as castle necklace. Neurological manifestation would be in form of posterolateral cord degeneration, which is usually associated with chronic deficiency, right? Coming to the other vitamin deficiency, the pyridoxine deficiency would be in form of peripheral neuropathy and refractory seizures. One vitamin deficiency, this also question comes in your exam: neonatal seizures caused by one vitamin deficiency. Which vitamin deficiency is responsible for one kind of neonatal seizures? Yes, the answer is pyridoxine. Always remember that pyridoxine deficiencies can give rise to neonatal seizures also. And in hematological manifestation would be microcytic anemia. Cyanocobalamin usually presents with pernicious anemia, that is your megaloblastic anemia, and neurological manifestation would be subacute combined degeneration of nerve cord and peripheral neuropathy. Biotin deficiency usually seen when the raw eggs are consumed. Always remember raw eggs, because they contain avidin, and avidin binds biotin and prevents its absorption, leading to biotin deficiency. So biotin deficiency, any vitamin deficiency which occurs because of consumption of raw eggs, always remember the answer is biotin. And here what you get to see a dermatitis, glossitis also, and hypercholesterolemia. And apart from that, we get to see manifestations on the head and mouth in form of dry scalp, right? Then folate deficiency usually, manifest as megaloblastic anemia, and pantothenic acid deficiency would manifest with burning feet syndrome and insomnia. So these are few vitamin deficiency we should be aware of. Coming to the question, which vitamin deficiency give rise to lesions seen in the image? Can you see this lesion? Yes, very clearly. This is nothing but Castle's necklace, which is usually seen with niacin deficiency, part and parcel of photosensitive rash because of the niacin deficiency, seen in these children. And this disease known as pellagra, right? And this is usually seen in areas where there is excessive consumption of maize, right? Okay, let us come to trace elements deficiency. Quick. Zinc deficiency gives rise to ectodermal enteropathica. This question has come in your previous years. You should be aware of ectodermatitis enteropathica. It is a genetic disorder where there is a mutation in certain genes which is responsible for the child developing zinc deficiency and the manifestation of acrodermatitis enteropathica. Copper's deficiency results in Menkes disease. Again, there is problem with the transport of copper. So the copper absorption does not take place. There is excess of copper in the intestine, but there is less copper in the peripheral tissues, leading to Menkes disease. How does it manifest? We will just see. Selenium deficiency results in Keshan's disease. Iodine deficiency, especially seen in endemic areas where there are, iodine deficiency exists, foothill of Himalayas. So there you get to see goiter or cretinism. And very importantly, chromium deficiency results in glucose intolerance. Keshan's disease, I would like to add, usually seen in the Keshan province of China, where you get to see cardiomyopathy. And cardiomyopathy is the presenting feature of Keshan's disease because of selenium deficiency, right? So this is the question, this kind of question has come, although I have given a twist to the question, but these questions have been repeated in the past in your exam. So we are giving a twist so that you know about the topic well. So a child comes to you with diarrhea and eczematous skin lesions, chiefly around the mouth. Can you see this eczematous lesions? And perineal area. So this you can see which deficiency is a child suffering from. Straight halwa question, as I call it. This is nothing but zinc deficiency, right? So this you should be aware of, right? Okay, now let us come to Menkes disease is due to deficiency of, we just saw it is due to deficiency of copper. What is Menkes disease all about? Let us read up that. So Menkes disease, you should know, is a X-linked recessive fatal disorder because of the impaired copper absorption and transport from the intestine, usually has a fatal outcome. As you can see, even Wilson disease is because of the impaired transport of copper. You know, there's a problem with the ceruloplasmin in Wilson's disease. But Menkes disease also, there is some mutation in the transport protein, and because of which even ceruloplasmin is low in these cases also. But it is a fatal disorder, unlike Wilson, where we can take some corrective steps and increase the life expectancy of the suffering individual. But Menkes disease usually has a fatal outcome. What are the clinical features? Usually what you get to see is hypotonia, and you can see kinky hair is there, okay, and there is hypopigmentation of the hair, very characteristic of Menkes disease. Apart from this, these children usually have chubby rosy cheeks. You can see chubby rosy cheeks are there, which is so very characteristic of Menkes disease. And there is, apart from this, there's neurological involvement. You can see it involves the brain, it involves the skin and the hair, and it may also involve the bones. So neurological involvement is usually in form of optic atrophy and seizures, and mental retardation would be seen, right? And there could be neurological regression of milestones can be seen in children suffering from Menkes disease, right? So this is how the brain is affected in case of copper deficiency. Seizures, usually myoclonic kind of seizures are seen in Menkes disease. Remember, Menkes disease is because of the copper deficiency. That is what you have to remember right now, right? And lab findings would be hypocupuremia, that means low serum copper. This means low serum copper, low plasma ceruloplasmin, neutropenia, anemia, microscopy of the hair. If you see, what you get to see is trichorexis nodosa. What do we mean by trichorexis nodosa? Is fracture along the shaft of the hair. That is what is known as trichorexis nodosa. Pillae torti may be seen, that means twisted hair, and the treatment is copper histidine therapy. Again, I have shown you this is the kinky hair and the rosy chubby cheeks, very typical of Menkes disease, right? Okay, then let us move on to the next topic, best marker for long-term nutrition. Sometimes long-term may be, substituted by chronic nutrition. Always remember, for chronic nutrition, we always see the height for age. That is what reflects the chronic nutrition. Sometimes height for age, or maybe in the options, height for age may not be given, stunting might be given. So stunting keh lo ya height for age, that is a marker for chronic nutrition, right? Another very favorite question of the examiner is, what is the fluid of choice for shock in a child with severe acute malnutrition? For severe acute malnutrition, remember, when you are talking about child who has SAM is severe acute malnutrition, you have to keep in mind that his total body sodium is very much increased. Remember that always, right, before you start the IV fluid therapy. And his total body potassium is totally decreased, right? So this has to be kept in mind. So that means giving normal saline in this child would not be very favorable to the child, because his total body sodium is already on the higher side. He requires a fluid which is deficient in sodium and maybe having potassium also. And very importantly, since he is suffering from severe acute malnutrition, some amount of glucose would be really favorable for this child. So what do we do? Right. So what we do is, we usually go for the ringer lactate and not normal saline. Ringer lactate is preferred. Now the question arises, why ringer lactate and why not normal saline? So see, if we have to see the fluid composition, right, let us draw a comparative chart between ringer lactate and normal saline, and then probably you will understand. So this is the normal saline, this is ringer lactate. And if we have to write the sodium composition of this normal saline, we all know this is 0.9%, sodium over here. So that means 154 milliequivalent per liter of sodium is seen in normal saline or found in normal saline. Ringer lactate, there will be 130 milliequivalent per liter, very importantly. Then what about the chloride? Chloride again is 154 milliequivalent per liter, as same as sodium, but in Ringer lactate it is 109 milliequivalent per liter. What about potassium? Always remember NS, there is no potassium. Why will potassium? Name is normal saline. Why should potassium be there? But here in Ringer lactate, it is 4 milliequivalent per liter. Right, so that is why Ringer lactate is preferred as compared to normal saline, especially while going for resuscitation of a child suffering from severe acute malnutrition. Remember, for any normal child who's not a case of SAM, we can use either NS or RL. There, it does not matter at all. But in SAM, severe acute malnutrition, we need to go very easy on sodium and try to supplement potassium, because otherwise this child will end up with pseudo paralysis. That means he will be having hypotonia because of the hypokalemia and will not be moving his limbs, which will not be a good sign. We don't want the child to go into hypokalemia. So that is why we want to replenish the potassium stores, and we have to give sodium very cautiously, because already his total body sodium is high. So that is why we go for Ringer lactate along with 5% dextrose. That would be favorable because the child is a case of SAM. Anyways, he would be having hypoglycemia. So the correct answer over here would be giving Ringer lactate with 5% dextrose, and not only Ringer lactate, and definitely not giving normal saline. And anyways, the second option, 10% dextrose, is never used as a resuscitation fluid, right? So therefore, our answer is going to be the D option. Okay, then hypoglycemia in malnourished child is defined as blood sugar less than. Yes, you have to remember this cutoff. It is 54 milligram. Blood sugar or blood glucose less than 54 milligram per deciliter, or if they might ask you millimole per liter. So please remember that value is 3 millimole per liter. So 3 millimole per liter, right? That will, that is the cutoff for causing, for actually labeling a child suffering from hypoglycemia or not. What about hypothermia? What are the cutoffs for defining hypothermia in a child suffering from severe acute malnutrition? So that all depends whether we are going for the rectal temperature or we are going for the axillary temperature. So because the cutoffs for both the sites is different. For rectal temperature, any temperature which is less than 95.5 degree Fahrenheit or less than 35.5 degree centigrade is hypothermia. For axillary site, this cutoff is 95 degree Fahrenheit or 35 degree centigrade. So anything less than that is considered as hypothermia. Remember, severe hypothermia in SAM is defined as less than 32 degrees centigrade. So that also you should know the cutoff. Simply sometimes they may ask you these straight away questions and you should be aware of them, right? Now let us move forward. During survey conducted to determine the prevalence of malnutrition, a child with features depicted in the figure was seen. Which of the following statement is false about the following child? So remember, so by seeing the figure, now tell me, what do you infer? Is this child a case of Kwashiorkor or is this child a case of marasmus? Tell me. I'm waiting for your answer. Yes, you are absolutely correct. This is nothing but Kwashiorkor. Yes. Why did I say Kwashiorkor is? Look at his pot-bellied, number one. Look at his hair. These two are giveaway signs which tell us that this is a child of Kwashiorkor and not marasmus. Marasmus would not be having pot-bellied, number one. He or she would be totally wasted. Plus the hair changes or the hair signs are not seen in marasmus. They are seen in Kwashiorkor, right? Now let us see the question. The main sign of the above disease is bilateral pitting edema. Yes, this is correct. This condition is characterized by monkey faces and baggy pants appearance of gluteal region. I don't think so this is correct, because this is more a feature of marasmus, while this child is not a case of marasmus, right? The child needs adequate amount of proteins. Of course, Kwashiorkor occurs because of the deficiency of protein. So yes, the child is needing proteins. Affected children are apathic and irritable and have a very poor appetite. So that is the most challenging thing while managing a case of kwashiorkor. The problem comes over here, poor appetite. So appetite is actually this, right? So poor appetite is the case, and that is why it is so difficult. The prognosis is not very good for for children suffering from kwashiorkor, while the prognosis is very favorable when we manage a case of marasmus, because the best thing about managing a child with marasmus is at least the appetite is good, and the intake of the calories and the replenishment would be a smooth process rather than the tumultuous process what we see in case of kwashiorkor, right? So this is the correct answer over here, since they are asking about the false statement. So correct answer over here is going to be the B option, because B option is a feature of marasmus and not kwashiorkor, right? So something we should know about WHO classification of malnutrition, very, very important. These are the 3 criteria we should be aware of. We have to go for weight for height, height for age, and symmetrical edema. If the symmetrical edema is not there and the weight for height and the height for age both fall between -2 to -3 standard deviation, we call it moderate malnutrition. If the edema is there, symmetrical edema is there, and the weight for height and height for age both are less than -3 standard deviation, then this is what is severe malnutrition in as per WHO, right? Now, weight for age, is this a criteria to be used? No, this is a thing of the past, not used. But anyways, we should be knowing that if the weight for age is between the -2 to -3 standard deviation, we call it moderate underweight, and if it is less than -3, then we call it severe underweight. Always remember, straight away they ask you, wasting is a sign of, yes, it is a sign of acute malnutrition. Please remember this. Then they will ask you, stunting is a sign of, in one form or the other, it is a sign of long standing, that means the chronic malnutrition. Right? So straight away, sometimes straight questions come and you should be able to answer them correctly. Coming to the assessment of malnutrition, we know this is nothing but a Charcot's tape, and this is used to measure what? Mid-upper arm circumference. And this is usually, mid-upper arm circumference is useful in assessing malnutrition in the age group of 6 to 59 months. One more thing which you should be knowing is, as per the recent update, MUAC, mid-upper arm circumference, is no longer a age-independent criteria. Remember, now it has become both age and gender-dependent criteria, right? But still we are continuing with our old usage that less than 11.5 centimeter is still severe wasting. That's what I'm going to tell you right now. But please remember that nowadays, as per the latest guidelines, mid-upper arm circumference is no longer age independent. Once upon a time, we used to call it age independent, and that is why there was a universal value that mid-upper arm circumference in this age between 11.5 to 12.5 centimeter would be moderate malnutrition, while anything more than 12.5 centimeter will be normal, and anything less than 11.5 centimeter will be severe malnutrition, right? That was what we used to read, and we are still reading this. But please remember, if a direct question is asked, is MUAC a age independent criteria, you have to answer no. It is no longer a age independent criteria. It has become, now the charts are available both for age and the gender. That means there are different charts for the boys and different charts for the girls for assessing mid-upper arm circumference. This should be very clear. But of course, if the conventionally they ask you what is the criteria for severe malnutrition as per MUAC, then you should know the criteria is less than 11.5 centimeter. 11.5 to 12.5 is moderate malnutrition, and anything more than 12.5 as per the Charcot's tape lies in the green category. This lies in the red category, and this lies in the yellow category, right? So sometimes they ask you the category also. The yellow category, what is the MUAC? So you should know it is 11.5 to 12.5. Red is less than 11.5. Green is more than 12.5, right? So this should be clear. Okay, now what are the difference between kwashiorkor and marasmus? Very thorough, very nicely you should be knowing. You should know that occurrence of marasmus is more common, kwashiorkor is less common. Thankfully, edema is present in kwashiorkor, absent in marasmus. Activity, the marasmus children are active, while the kwashiorkor children they are apathic and they are, very much irritable. Appetite is good in marasmus, poor in kwashiorkor. Liver enlargement is a feature of kwashiorkor. This is asked in your exam. You should know this. Mortality is more in kwashiorkor as compared to marasmus. Recovery is better in marasmus as compared to kwashiorkor, and infections are more there in the kwashiorkor. Why? Because there's deficiency of proteins, there's deficiency of antibodies as a result. Especially the IgA antibodies are severely lacking in kwashiorkor, and hence the, IgA is a protective antibody for your respiratory mucosal surfaces. So they are more prone to develop skin and respiratory tract infections as far as the kwashiorkor is concerned, right? Okay, so there are certain pictures you should be aware, you should be clear with. So this you can see again a pot-bellied. So this is a case of kwashiorkor. This is a totally marasmic, wasted child. So it's a case of marasmus, and you can see at his face he's also, this is a alert look. This is, somewhat a irritable look, right? Again, here we cannot see the faces, but we can see the pot-bellied. So this is again a case of kwashiorkor, right? Now, let us come to this. This is what is known as baggy pants appearance. Please remember this baggy pants appearance, where you can see severe wasting occurring in the gluteal region. There is total loss of the fat pad, right, of the gluteal region. That is what is giving the loose folds of the skin, and these loose folds of the skin are known as baggy pant appearance, right? Now, this is also again totally, wasted child. So, I would label the child as a marasmic child, right? Then you can see, I told you the skin and the hair changes are so very characteristic of kwashiorkor, right? So this you can call it crazy pavement dermatosis, right? And this is again a kind of reason for frequent infections. You can see the skin barrier is totally denuded, totally damaged. So these children are prone to develop more infections. The kwashiorkor infections are more common because you can see the poor condition of the skin. So crazy pavement dermatosis, right? So, or flaky paint dermatosis, also known as flaky paint. You can see it seems as if the paint is coming off. So flaky paint dermatosis, and these raw areas, they serve as nidus, they serve as bed for the proliferation of the bacteria, and hence more number of infections occur in kwashiorkor, right? So this is the flaky paint dermatosis. Okay, then this is the hair signs. You can see again hair signs. If I am telling you, that is the feature of kwashiorkor. So this is the flag sign. You can see the alternate bands of pigmentation, and then there is a depigmentation. Depigmentation refers to the period when the nutrition was inadequate. So this is nutrition was inadequate. So therefore, the pigment could not be synthesized of the hair. And then probably the child got good nutrition. Again, the pigment came, and then again you can see there's a zone of depigmentation. So this is known as alternate bands of pigmentation. Depigmentation are referred to as flag sign. And then you can see this is a sparseness of hair. Can you see that? The scalp is visible, and this shows easy pluckability of the hair. That is why the hair are so sparse. Again, this is a feature of kwashiorkor. Why am I telling you all this? All comes in your MCQs. Rather than getting you MCQs, and let me drill this inside you so that you remember all this, right? Now, finally, we ended up with features of severe acute malnutrition. This is defined in 6 to 59 months of age. Any one of the following three criteria is referred to as a feature of severe acute malnutrition. Again, as I would tell you, this is again your घोट के पी जाओ वाली slide. आपको याद होना चाहिए. First of all, weight for height less than -3 standard deviation, presence of bilateral pitting edema. That is the second criteria, and the third criteria is MUAC less than 11.5 centimeters. Any one of the following three criteria if present indicates the child is having severe acute malnutrition, right? In a child below 6 months of age, MUAC is not used as a criterion. That is a very important thing which you should remember, right? Okay, then let us come to the next question. A 2-year-old child weighing 6.5 kg. So we have just done growth, and we know the normal parameters, and we just saw that the birth weight, it quadruples at 2 years of age. So assuming an average birth weight of 3 kgs and quadruples means 2 years wala bachcha should be around 12 kgs. Now, let us say he was not born 3 kgs. So at least he should be anywhere between 10 to 12 kgs if he was of the lower birth weight also, right? But he's weighing 6.5 kg. So that means you're very sure you're dealing with this malnourished child. Now, presents the casualty with history of vomiting and diarrhea for the last 2 days. On examination, the skin pinch over the anterior abdominal wall goes back very slowly to its original position. Interpretation of the skin pinch test in this child will be very important question. They are actually testing your knowledge of both growth and malnutrition. So this is again a integrated question they have integrated in pediatrics itself. So tell me, what will be your interpretation as per the skin texture or the skin pinch, the interpretation of the skin pinch test would be? See, very importantly, whenever there's a child with malnutrition, remember in a children with malnutrition, skin pinch is not a reliable test for assessing dehydration. Why? Because anyways, there's a loss of subcutaneous fat. So anyways, the skin pinch is going to be delayed. So that is not a reliable marker of dehydration. A more reliable marker would be testing the moistness of the oral mucosa. So you can go for oral mucosa, you can test the moistness of oral mucosa. You can also check the pulse rate. Even that will give you an idea of dehydration. You can also go for the urine output. You can measure the urine output. Even that will tell you the state of dehydration of this child, and not relying on the skin pinch test. So my answer here would be that skin pinch cannot be evaluated in this child. Very, very important. Please keep this in mind. This was a googly question, a very nice question, which should, trying to test your knowledge of both growth and malnutrition. Now, moving ahead with the next topic, a post-term neonate is a neonate that is born beyond. We know this. Post-term is anywhere between 37 to less than 42 weeks of gestation, right? So, post-term would be anything more than 42 and pre-term will be anything less than 37 weeks of gestation. So, my answer is going to be what over here? It is going to be the D option over here. Apart from this, there are other definitions we should be knowing. VLBW baby, very low birth weight baby, is less than 1500 grams, right? Then ELBW, that means extremely low birth. Sometimes, certain direct questions come and then, we'll be repenting. Why didn't we read these certain, very easy definitions? So, ELBW baby is when it is less than, the birth weight is less than 1000 grams. Then sometimes they may ask you, what is macrosomia? Yes, we know macrosomia is more than 4 kgs, right? So these are certain definitions with regard to the neonatology. Now, vitamin K supplementation is given to neonates to prevent what? Yes, it is given to neonate to prevent hemorrhagic disease of the newborn, right? So HDN, we know. Vitamin K, is very important for the synthesis of 2, 7, 9 and 10. What am I talking about? Yes, I am talking about the coagulation factors or the factors which participate in the coagulation cascade. So, 2, 7, 9, 10 are vitamin K dependent factors, and therefore, every child should be given a shot of 0.5 to 1 milligram of vitamin K1. K1 is the preparation which is preferred. Of course, if K1 is not available, then you can go for K3, but then K3 is responsible for inducing hemolysis. So we should always go for K1. 0.5 milligram would be for preterm and 1 milligram for the term child. So hemorrhagic disease of the newborn is prevented by giving vitamin K administration soon after birth to every child. It should be given. Okay. Then, which of the following is not true about colostrum? Colostrum is the first milk which comes out of the breast, right, soon after the birth of the baby. So, does it contain IgA? It is teeming with IgA. It is abundant. I should write over here abundant. Then it is lemon yellow color, very true. It is rich in protein and amino acids, yes, and it is high amount of sugar and fat. Now, this does not go well. D option is not correct over here because you should know in the initial parts, the colostrum that is full of antibodies, more of protein and minerals and vitamins, and very less of sugar and fat. And anyways, the requirement in the first 3 days of life is quite less for the sugar and fat. So therefore, what is more required is the immunity, which this colostrum provides, and that is why the correct answer over here is going to be the D option, because the colostrum is not high in sugar and fat, right? Coming to the next question, nutrient deficient in breast milk is. So you should be knowing that your vitamin D is definitely less in breast milk, right? So that should be your answer. Straight away, the answer is D. Is vitamin C, many times, certain children, they ask you, ma'am, what about vitamin C? Vitamin C is not present in milk anyways. Please remember, bacho, in breast milk, vitamin C content is very good, in fact, right? It is around 5 to 15 milligram per 100 ml, right? So that tells you that, the vitamin C content of the breast milk is still much, much better than the cow's milk, where the vitamin C content in cow's milk, if I have to see, is around 0.2 to 2 milligram per 100 ml. Can you see the difference? And moreover, if you boil this, then this also becomes 0. So therefore, vitamin C content of the breast milk is still good. So you will not go for vitamin C being deficient. You will go for vitamin D being deficient in the breast milk, right? Okay, now coming on to the contraindications to the breastfeeding. So these are certain contraindications you need to keep in mind. Straight away, question has been asked in the past, right? And the correct over there would be, so which of the following conditions are contraindications for breastfeeding? One would be, let us say this. Another option would be the mother suffering from hepatitis B, or the mother suffering from active tuberculosis on treatment. And the fourth option may be the mother having CMV infection. See, one thing should be very clear. CMV does get transmitted in the breast milk. This should be very clear to you. But do we stop breastfeeding in a mother who we know is CMV infected? No, we don't. Because the benefits of breastfeeding far surpass the ill effects of CMV if passed through the breast milk, right? So therefore, even with a known mother infected with CMV, still the breastfeeding is not contraindicated. This should be very clear. Another thing should be clear is active tuberculosis, mother with active tuberculosis but on treatment. Again, breastfeeding not to be stopped at all if the mother is taking treatment. Of course, if she's an open case of tuberculosis and not taking treatment at all, then definitely one has to reconsider whether to give breastfeeding or not. But definitely on treatment, there's no contraindication. So straight away contraindication is when the child has galactosemia or lactose intolerance. Breast abscess is a relative contraindication because it's a painful process. Of course, we would like to defer breastfeeding for a certain time, but not an absolute contraindication. Mother, if doing some substance abuse or having severe psychosis or neurosis, again, that is a contraindication for breastfeeding. So drugs such as antithyroid drugs, except propylthiouracil, radiopharmaceuticals, and anti-cancer drugs. So these are all, if the mother is on any of these drugs, then that is a contraindication for breastfeeding. So breastfeeding is not to be done. Another very important topic, from where lots of questions have been asked in the past is the different compositions of the human milk, the cow's milk and the buffalo's milk, right? So like you should be aware of the composition. A rough idea should be there, as you should be knowing. You should be aware of this highest water content is seen in which milk. So that is a human milk. So I'll write down over here human milk so that it becomes easy for you to remember. Highest energy, fat and protein content is seen in which milk? This is seen in buffalo milk. Remember that. So buffalo milk, you get to see highest content. Then highest carbohydrate content is seen in which milk? Yes, over here again, the trophy goes to human milk. That means the breast milk. You get to see the highest carbohydrate content. Then highest calcium and phosphorus, again over here the first position goes to buffalo milk. You have the highest calcium and phosphorus ratio. So you can see calcium and phosphorus is much more as compared, almost 10 times more than the breast milk. But the important thing over here is the ratio, calcium to phosphorus ratio is 2:1. This is required for adequate absorption of calcium from the intestine, and this is perfectly seen in the breast milk, and hence children being breast milk, they do not develop hypocalcemia because the absorption of calcium is very much better in breast milk as compared to cow's milk or buffalo's milk. So always remember that, right? Then vitamin C content you can see is highest in the breast milk. Iron content is definitely deficient in the breast milk, right? And the important what other thing which has been asked in the past in your exam is the protein content, that is very much lower in our milk, and that is actually very protective for the growing baby, because increased protein content in the breast milk means extra solute load on the kidneys, and we don't want that because the kidney in the newborn period is an immature state, right? So a lower protein content is actually a favorable thing for the baby's kidney, so that with the passage of time the kidneys can mature and they don't have to handle that much solute load, right? So we should be knowing this. Then, as I was telling you, the human milk is richer in vitamin C as compared to the cow's milk. Now again, the questions have been asked on attachment, so we should be knowing. So the good attachment will be wide open mouth. Very importantly, the angle between the upper and lower lip should be an obtuse angle, while here if you can see this is an acute angle, right? So this should be an obtuse angle. The chin should be touching the breast. You can see this here, it is not touching. And the lips, the lower lip especially, should be everted. It should be everted. It should be turned outward. Very important, right? So this all shows you that there's good attachment of the baby's mouth to the breast. One more this thing is over here, you can see the lips are, this is a everted lip, which is a sign of good attachment, right? And very importantly, the lower portion of the areola should not be visible. That means the complete lower areola should be inside the mouth. Upper areola, even if the 1/3 of the upper areola if visible, that is normal. Upper areola 1/3 is normal if visible, but the lower part of the lower areola should not be visible. It should be completely in the baby's mouth. So these all are key points of good attachment in the child. Why am I telling you all this? These are all that has been asked in your exam, right? Now, some important points. Neonatal jaundice detectable at a minimum serum bilirubin of 5 mg per deciliter, right? Maximum time to wait for the passage of meconium is 48 hours, because it is very clearly given in Nelson that 98% of the babies would finally pass their meconium by 48 hours of life. Previously, we used to think 24 hours, but it's very clearly given 48 hours. So we wait for 48 hours before, starting with our investigations and, thinking about Hirschsprung's disease and so on, right? Then ratio of chest compression to positive pressure ventilation in neonate is 3:1. So usually we do, 90 to 30, 90 chest compressions to 30 times breath we give. Then bag and mask ventilation is totally contraindicated in, yes, it is contraindicated in, you guessed it right, diaphragmatic hernia. So this you should be clear. Straight away MCQs will come, so you'll be able to answer. Now, this swelling was noticed in this child after birth, which persisted till 10 weeks after birth. What is the diagnosis in the child? So, you can see there's a localized swelling over here. Again, in this X-ray also you can see, and this is persisting till 10 weeks. Will that be caput in any way? No, that will not be caput. Caput usually goes off by 2 to 3 days of birth, right? Within 2 to 3 days of birth, caput would disappear. So, this is not going to be caput. Then can it be subgaleal hemorrhage? Remember, bachcho, subgaleal hemorrhage is an emergency. Subgaleal space has a potential volume of around 260 ml. So 260 ml of blood can collect, and that will push the child into shock, and this child will definitely need resuscitation. And if you don't do it, then this will have a fatal outcome if you do not resuscitate this child. So this would not be persisting till 10 weeks anyways, right? Then encephalocele is a neural tube defect. We are going to discuss it in detail. This does not, present in such a way. So this kind of presentation is nothing but cephalhematoma, which is a subperiosteal hemorrhage, usually seen following a delivery by forceps or ventouse, a violent kind of delivery, and then there's a rupture of the bridging veins, in the subperiosteal region, and that is why there is collection of the blood in subperiosteal region, which takes some time to get resorbed, and usually during the process of resorption may result in exaggeration of physiological jaundice, right? So that is the whole story behind cephalhematoma or cephalhematoma, as you want to call it. So this is definitely our answer becomes. So definitely our answer becomes cephalhematoma over here, right? So this you can see there's a comparison between the three important scalp swellings which we see soon after birth. So cephalhematoma, you can see this is the periosteum over here, and below the periosteum there is. So this is the periosteum over here, and this is the blood collection below the periosteum. Now subgaleal hemorrhage, I was telling you, this is a space, potential space beneath the gallia aponeurotica, and here you have the collection of blood, and again this space is around 260 ml volume, and this can hold a lot of blood and can push the child into shock and requires immediate resuscitation. Now what is caput? Caput is nothing but it is the swelling in the subcutaneous tissues of the scalp, subcutaneous tissues of the scalp, right? So that is what is caput succedaneum, and this usually dissolves, in 2 to 3 days of life, while cephalhematoma will take some time. Another difference is soon after birth, cephalhematoma and subgaleal hemorrhage would not be visible. Remember, would not be visible soon after birth. They will take some time to appear. Usually around, let us say in case of subgaleal hemorrhage, usually takes around 6 hours to appear, while cephalhematoma may take around 12 to 24 hours to appear. While caput succedaneum is very well visible during the process of birth itself, is present at birth, it is very well visible. So that is again one of the differences between cephalhematoma and subgaleal hemorrhage, and of course caput succedaneum, right? Okay, so again, let us do one more question. The child presented with this swelling at the time of birth, which decreased in size in the next 2 to 3 days. All of the following are features of this swelling except. So you can see there's a diffuse swelling, not limited to any particular bone, because cephalhematoma is limited to a particular bone. It is limited to a subperiosteum. It is a collection of blood beneath the periosteum of a particular bone. That is what I'm talking about, cephalhematoma. But in case of caput succedaneum, it's a diffuse kind of swelling, right? And it decreased in size in the next 2 to 3 days. All the following are features of the swelling except. So that means they are asking us about caput succedaneum. Crosses suture lines, of course, it's a diffuse swelling. It will cross the suture line. It is due to edema of the scalp. The answer is yes, it is because of the edema of the scalp. It is associated with hyperbilirubinemia. No. It is a benign condition. Yes. So answer is, the correct answer over here is going to be the C option, because caput has got nothing to do with hyperbilirubinemia. Hyperbilirubinemia would be seen in association with cephalhematoma. Yes, so that you have to remember. Okay. A child is born at 30 weeks of gestation. What is the preferred mode of feeding? So we should be aware of how do we decide the feeding? Remember, we decide the feeding according to the maturation of the feeding skills in the child, right? So if the child is of less than 28 weeks, inadequate sucking efforts is there's lack of propulsive gut motility. So there's no point in putting any any feeding material inside the gut, because the gut is not moving only, and that would lead to gut necrosis if the material is kept at one place itself, right? So what we prefer is the IV fluids in that case. If the child is between 28 to 31 weeks of gestation, then there's a lack of coordination between the suck, swallow and breathing. Again, there is no point in, introducing the food directly in the mouth and let the child swallow it on its own, because there is lack of coordination. So what we would do is we would go for a orogastric or a nasogastric tube feeding. And as the child approaches 31 weeks of gestation, we would like to go for occasional spoon or palate feeding, because that is what the next technique we are going to use in the coming days. And when finally the child crosses the 32 weeks of gestation, then the preferred mode of feeding is by spoon or palliative, because the coordination between the breathing and the swallowing begins, but still the sucking and breathing and swallowing coordination totally that is not there. So since breathing and swallowing coordination has begun, so we try to exploit that coordination by using a spoon or a palliative feeding. And finally, at more than 34 weeks of gestation, we will like to go for direct breastfeeding, because now the coordination between the suck, swallow and breathing has been fully established. Now, our child was at what age? It was 30 weeks of gestation. And if we see this, 30 weeks of gestation would come in this category. So that means we would go for orogastric or nasogastric feeding. So that is the correct option over here. There would be the A option where it is written orogastric feeding, right? Okay, so moving on to the next question. Again, a very high yield question has been asked multiple number of times. Identify this condition, or maybe sometimes they may give you a condition like this, or the third time, they may give you a condition like this. Now, what are these three conditions we're dealing with? Let us see. So, whenever you have a, sac like this coming out of the abdomen of the child, right, and covered by a membrane. So this membrane is nothing but peritoneum, and along with the intestinal contents, we can see there is some organ also over here, which is nothing but the liver. So liver or spleen may also come out along with the intestinal contents, but covered by a membrane. We call this condition as omphalocele. Remember that, that you have to remember. And then in next this thing, you can see there is only and only the intestinal loops which are coming out, and it is devoid of any covering membrane, number one. And number two, there are no, organs over here, only intestinal loops. So this kind of condition is known as, gastroschisis. Right, this is known as gastroschisis. So what is the difference between the two? So you can see in the gastroschisis, the peritoneal membrane or the peritoneal covering is absent, while in the omphalocele, the covering would be there. Then the contents of the sac would be the intestinal loops and the multiple organs in case of omphalocele, while in the gastroschisis, there is only and only the intestinal loops. Then position, very importantly, the omphalocele, it protrudes into the umbilical cord, while the gastroschisis is a defect in the abdominal wall, and it is usually to the right side of the umbilical cord. So you can see there is, these loops would be on the right side, while their omphalocele is usually into the base of the umbilical cord. So this is the difference. Now coming on to the next condition, and that is when we see something like this. What is this? This is nothing but ectopia vesicae. Ectopia vesicae means what you can see is nothing but the posterior layer or the posterior wall of the bladder. Okay, so there is complete ventral defect of the urogenital sinus and the overlying skeletal system, and there is failure or development of the lower abdominal wall in this case, and also the anterior wall of the bladder. So ectopia vesicae, there is failure of the development of anterior abdominal wall, important, plus the anterior wall of urinary bladder. So what you can see, this is the posterior wall of the urinary bladder. So this is outside, and obviously what comes out, there will be constant dribbling of the urine, there is increased incidence of the UTI, right, and renal failure in this case, even carcinoma bladder. If this is not treated well, then carcinoma bladder can also occur. Then there are two varieties, complete and incomplete variety. In the complete variety of ectopia vesicae, the pubic symphysis is not formed at all. So that is the complete variety and the incomplete variety, right? And apart from this, there would be some or the other, some problems of the genitals also. What is most striking is the constant dribbling of the urine, because you can see there's hardly any storage capacity in the body because the bladder is exteriorized, and anyways, the anterior wall of the bladder is also missing. So this kind of condition will be known as ectopia vesicae. So this you should be knowing. Then let us come to the next condition. In a neonate, there was discharge of meconium from the umbilical stump. Which of the following conditions should be considered? So when there's discharge of meconium from the umbilical stump, then what do we think of? So this we think of as vitellointestinal duct. This is a duct which is a communication between the yolk sac and the primitive gut. So this is the primitive gut you can see, and this is the primitive gut, this is the yolk sac. And there is this communication which is a vitellointestinal duct, which usually involutes, between 5th to 8th week of gestation. It gets obliterated in that time, right? Now what happens is that with the duke, if this duct remains patent, then definitely there will be a communication between the intestinal region and the umbilicus, and because of that there would be outpouring of the meconium from the umbilicus, as is the case. Now there can be various kind of abnormalities or anomalies of the persistence of the vitellointestinal duct. So what kind of anomalies can be there? So there can be straight away intestinal fistula, vitelline fistula, what is that known as, and because of probably this is the case which is occurring in the question, and because of which there is outpouring of the meconium from the umbilicus, right? Or there can be vitelline cyst, where there would be proximal and the distal part of the vitelline duct is obliterated, only the middle part is the patent. Or there can be just the persistence of the vitelline cord, where the entire vitelline duct has been totally obliterated and just persisting as a cord. Or there can be, just like this, where the proximal part is, persisting as a outpouching from the gut with no connection to the umbilicus, and this we know as in the, this may create problems later on, because we know this is nothing but Meckel's diverticulum. And finally, there can be a combination of Meckel's diverticulum and vitelline cord, where the Meckel's diverticulum is connected by means of a cord to the umbilicus. So this vitelline fistula is probably the reason why there is outpouring of the meconium from the umbilicus. So we move back. So the answer over here is going to be patent vitellointestinal duct. Now what is omphalocele? We have already discussed. Ureterocele would not be visible outside. This kind of lesion occurs where the ureter enters the urinary bladder. So anyways, this is also out. Now, what is left is, what do you mean by patent urachus? I need to tell you this because there is a question on this also. So, patent urachus is nothing but, there is a duct known as allantoic duct which connects, this is the urinary bladder. Try to understand that. This gets connected to the umbilicus through a duct which is known as the allantoic duct. Now, this allantoic duct usually gets obliterated within 1 or 2 weeks after birth. But if it persists, then this is also known as urachus, and then we call it persistent urachus. And through the urachus, because the urachus establishes a communication between the urinary bladder and the umbilicus, there would be outpouring of the clear fluid from the umbilicus, which is nothing but a smelly clear fluid, and that is nothing but urine, right? So if the question asks you if there's outpouring of the urine or the clear smelly fluid from the umbilicus, what is your diagnosis? You will call it patent urachus. But if there's outpouring of meconium, then you will call it patent vitellointestinal duct, right? I hope this is clear. Moving on to the most important part of our discussion, a term baby is apneic and a heart rate of 40 per minute. What is the best intervention at this stage? The moment you see heart rate of less than 60 per minute, everybody goes for chest compression or chest compression and bag and ventilation. Please understand 3 things: heart rate less than 100 per minute, or if the child is apneic, or if the child is gasping. In all these 3 conditions, please remember, what do we do? What do we do is we go for positive pressure ventilation to begin with. When the baby is born, the first intervention is obviously the initial steps where you warm the baby, where you rub the baby, where you try to suction the secretions out of the oral cavity, and still after that assessment the baby is having this kind of condition, then the first and the foremost step is going to be positive pressure ventilation, right? Even after positive pressure ventilation, if now there are 2 scenarios: heart rate less than 60 per minute, or there is heart rate which is less than 100 or per minute, or let us say it is 90 per minute. What do we do? In both these conditions, please try and understand, we will go for ventilation corrective steps, and which we all know by the name of MR SOPA. So we have to go for ventilation corrective steps. Let me show you that. MR SOPA, ventilation corrective steps have to be taken. Now, even after taking 30 seconds of ventilation corrective steps, still the heart rate is less than 60, then the indication occurs of chest compression. So, what is the correct indication of chest compression? Hear me out. When the heart rate is less than 60 per minute, despite adequate ventilation. Adequate ventilation means the ventilation or the bag and mask which is producing a chest rise. Despite 30 seconds of adequate ventilation or despite 30 seconds after the ventilation corrective steps, if the heart rate is less than 60, then you will go for chest compression. So, in this case, the correct answer is going to be, it is going to be start bag and mask ventilation. Start with that. Of course, in the question, if they tell you the bag and mask has already been done and the chest rise is happening and still the heart rate is less than 40, then or it is 40, then you will add on chest compression. That means your answer will be the C option if the ventilation corrective steps have already been done. That means the positive pressure ventilation was already going on. I hope I am clear. You should be very clear with this neonatal resuscitation protocol, right? Now, let us move on to the next question. A baby born at 34 weeks of gestation started on positive pressure ventilation soon after birth because he is born limp and apneic. What is the percentage of oxygen to be administered with positive pressure ventilation? So, we know this, less than 35 weeks of gestation, we start 21 to 30% oxygen with PPV, and more than 35 weeks of gestation, we start with 21% of oxygen. I hope this is clear. And very importantly, the moment you start the child on chest compression, always remember this. Tomorrow they can ask you this question: with chest compression, what percentage of oxygen will you give on positive pressure ventilation? Then you will say, with positive pressure ventilation, I am going to give 100% oxygen. The moment you start chest compression, you increase this or this to straight away 100%. With chest compression, there is no 21% or 21 to 30%. But of course, before that, when you are giving only and only positive pressure ventilation, then you have to decide as per the gestation of the child, right? Okay. Let us move forward. So, in this case, what will be the answer? See, 34 weeks of gestation is there. So, I will go for 21 to 30%. Now, this is the settings we already know. The gas flow is 20 liters per minute. Rate of positive pressure ventilation is 40 to 60 breaths per minute. PIP, the initial peak inspiratory pressure is 20 to 25 centimeter H2O, and the positive end expiratory pressure is going to be 5 centimeter H2O. MR SOPA, we already know the ventilation corrective steps. Then this is the endotracheal tube sizes which you should know. Always remember only this and your entire thing will be sorted out. How do I remember? For 1 to 2 kg child, I use a 3 mm internal diameter endotracheal tube. So, for less than 1 kg, what will I use? I will use 2.5 mm internal diameter. For more than 2 kg child, I will use 3.5 mm internal diameter. What did I memorize? I memorized only this, and then from this I derived the upper and the lower mm internal diameter, right? So, that's how you have to remember the endotracheal tube size, right? Then epinephrine, when do you give? If the baby's heart rate remains less than 60 beats per minute, even after 30 seconds of positive pressure ventilation that inflates the lungs, right? That means the chest movement is there and there is 60 seconds of chest compression coordinated with PPV using 100%. That's what I was telling you. Using 100% oxygen, even despite all this, if the heart rate is less than 50-60 beats per minute, then you go for epinephrine. The dose, the only dose which you have to remember for the paper of pediatrics is, for the pediatrics portion, is the dose of epinephrine used in neonatal resuscitation. Remember, for the intravenous or the intraosseous, it is 0.02 mg per kg. If they ask you in ml per kg, that means it is just 10 times the dose. So, that means it becomes 0.2 ml per kg. Then endotracheal dosage is somewhat on the higher side because the endotracheal absorption is very erratic. Never ever preferred. Remember, the first option preferred is IV, second is IO, that is intraosseous, and the endotracheal route is the last route because there is very erratic absorption over here. So the dose is, are almost 10 times the dose. So 0.02 mg per kg becomes 0.1 mg per kg, and 0.2 ml per kg will become 1 ml per kg. So this what you have to remember, the dose of epinephrine, right? Okay. Then newborn is assessed by the Apgar score of 5 minutes after his birth. He is found to have a heart rate of 50 per minute, grimace in response to catheter guarded stimulation of nostrils. The color was pink. On examination, he showed active movements and had a strong cry. Calculate the Apgar score of the infant. So, let us calculate the Apgar score. Heart rate of 50 per minute. How much do I give? I give a Apgar score of 1 because less than 100 is 1. Then grimace in response, again I give Apgar score of 1. Then color was pink, that means the whole of the child was pink. I give a Apgar score of 2. On active movements, again what do I do is I give a Apgar score of 2, and strong cry I give a Apgar score of 2. Now what is the total score? So you can add 2 plus 2 plus 2 plus 1 plus 1. It comes out to be the Apgar score of 8 in this child. So you should be very thorough with your Apgar scores. A question which has been time and again asked in your examination, right? Okay, then which intrauterine infection is this? So what you can see is microcephaly, patent ductus arteriosus and cataract. Straight away your answer should be congenital rubella syndrome, right? Okay, then which of the following is not a common manifestation of congenital rubella? Is it deafness? It is there. Then PDA, we have just seen. Cataract, yes, you remember the mnemonic CCD. C stands for cataract, C again stands for congenital heart defect in form of PDA, and D stands for deafness, right? So CCD, that is your congenital rubella syndrome. What is not seen is aortic stenosis. So our answer becomes aortic stenosis is my answer for this question, right? That is not a common manifestation of congenital rubella. Okay, then following constellation of signs and symptoms is seen in which intrauterine infection. So you can see the child is having, constant secretions coming from his nose. And what you can see is some clouding over here. So periostitis is seen. And then these are peg-shaped upper teeth. So what are these known as? So these are known as Hutchinson teeth. Hutchinson teeth. So what am I talking about? Yes, you are correct. I am talking about congenital syphilis. This is the first sign of congenital syphilis, which is known as snuffles. And this is what you are seeing as periostitis. Periostitis is again a feature of congenital syphilis, which you need to remember, right? Okay, then a 3-year-old child presents with complaints of cough, coryza, conjunctivitis, fever for 4 days. He now has a maculopapular rash which started from behind the ears and is spreading to the rest of this body, and his oral mucosa has developed some lesions, which is the most likely diagnosis. So you can see there's a cough, coryza, conjunctivitis, and the rash has come on day 4, starting behind the ears, right? This is so very typical of nothing else, but yes, you guessed it right. This is nothing but measles. And what is shown over here? Anybody can tell me what are these? These are nothing but Koplik spots, right? So Koplik spots are visible on the oral mucosa, right? And this is a maculopapular rash starting from behind the ears, from the from the hairline, from the upper part of the neck, and then coming onto the face and then spreading to the rest of the body. So our diagnosis straight away becomes measles, right? A worried mother brought her 6-year-old unimmunized child to the ER with complaints of fever, cough, and shortness of breath. A pseudo membrane was noticed over the tonsils, on which bled. This is bled on trying to remove it, and a bull neck appearance of the neck was noticed. What is the most likely diagnosis? So when you have these options, when you have a pseudo membrane somewhere and you have a cervical lymphnopathy contributing to bull neck, so this is nothing but we are talking about diphtheria. So you should know to identify these infectious disorders very commonly asked in your exams, right? Now, what to suspect? So, I've just summarized what to suspect when the rash develops after fever disappears. So, this is nothing but your 6th disease, also known as exanthum subitum. Okay, right? So remember this, exanthum subitum keh do, roseola infantum keh do. So typically what happens is the rash will develop when the fever will disappear. So this is this. Now child develops a slapped cheek appearance. We all know this. This is known as your 5th disease, also known as erythema infectiosum, right? Erythema infectiosum. The causative agent over here is parvovirus B19, right? The causative agent over here was HHV6. Another feature of Rosella infantum is we get to see what? Yes, you guessed it right. In the mouth, we get to see Nagayama spots, right? Nagayama spots, which are nothing but ulcers at uvulopalato-glossal junction, right? Okay, then child develops pleomorphic rash starting from the trunk within 24 hours of fever. What is your diagnosis? Yes, this is nothing but varicella, or popularly known as chicken pox. Within the first day of fever, you get to see a rash which starts from the trunk and which is, in various stages of development. You will get to see vesicles also, fluid-filled vesicles and macules and papules, right? So, these varying kind of rash is a feature of varicella. Child develop vesicles on palms and soles and ulcers in the oral cavity and maculopapular region on elbows, knees and gluteal region. What is your diagnosis? Yes, my diagnosis is HFMD, which is caused by Coxsackie virus, right? So, Coxsackie 16 or enterovirus 71, right? Enterovirus 71. So, these are the causative organisms and the diagnosis which we should know, right? So, this is your pleomorphic rash. You can see there are fluid-filled vesicles. There are some macules also. There's an ulcer also over here. So, this is your chicken pox. So, when you get a question like this or a scenario like this, think of chicken pox, right? 8-year-old boy presented with fever, bilateral cervical lymphnopathy with prior history of sore throat. There was no hepatomegaly. The peripheral blood smear shows more than 20% lymphoplasmacytoid cells. That means atypical cells. Most likely diagnosis out of these 4 is straight away I will go for a diagnosis of infectious mononucleosis, not acute leukemia, but infectious mononucleosis. So, when do we suspect infectious mononucleosis? If they would have given me a history of epitrochlear lymphnopathy, I would have been more happy because this is very, very specific for infectious mononucleosis. Apart from that, what do we see? Swollen tonsils, fever, fatigue, right? Sore throat is there, swollen lymph nodes they have already mentioned, and we also get to see hepatosplenomegaly. And what is the treatment? Nothing, just conservative treatment. Give lot of fluids, lot of bed rest has to be advised, and a good antipyretic in form of acetaminophen, that means paracetamol, or we can also go for ibuprofen for pain and fever. Very importantly, the contact sports have to be avoided like that of football, because there's a spleen is so much swollen, there's tendency for the rupture of the spleen. So therefore, one has to avoid contact sports in infectious mononucleosis, right? Okay, so this what we are talking about, there are fluid-filled vesicles on palms and soles, and then there are ulcers in the mouth, and there are, some macular lesions on the knees and elbow and the gluteal region. What are we talking about? We are talking about hand, foot and mouth disease. We just discussed it, right? Then erythema infectiosum, caused by parvovirus B19, right? We have a flap cheek appearance, and slowly this rash will, spread to the rest of the body. In the rest of the body on the trunk, this rash undergoes central clearing, and because of the central clearing, it gives a lacy appearance to the rash. The rash assumes a lacy appearance when it appears on the trunk, right? And this is caused by parvovirus B19. This can go on to also cause arthropathy. In pregnant individuals, if the mother gets parvovirus B19 infection, then the child might develop hydrops fetalis also, and even myocarditis is seen, right? And in young females, we also get to see arthritis or arthropathy following a parvovirus B19 infection. And very importantly, any child suffering from chronic hemolytic anemia, let us say if the child is having hereditary spherocytosis, or maybe the child is having sickle cell anemia, if infected by parvovirus B19, this child goes into what? Aplastic crisis, total shutdown of the erythroid production, or the lineage or the RBC production totally comes to a standstill. That is what is known as aplastic crisis, because this parvovirus B19 has a special tendency to infect the cell of the erythroid lineage, right? So this you should be knowing. A male child presents to you with painful swelling below the ear but no systemic manifestation. There have been 2 other similar cases in the friends of this village. What will you do? So you can see there's a good swelling below the ear, right? And it's a painful swelling and occurring in other children also, and this is most likely a communicable infectious disease. So what are we talking about? We are talking about mumps. Now, what is the management of mumps? So do we immediately hospitalize? Do we do incision and drainage of the swelling? Do we give antibiotics for the viral infection? Or do we give antipyretics and send the child back home? Of course, you guessed it right. The correct answer over here is the D option, where we will give antipyretics and send the child back home. Remember, a very dreaded complication is orchitis, right? It needs just support. Some kind of support to the testis has to be given to the testicular enlargement, and usually comes by the first or the second week of illness, right? And very importantly, and good thing about orchitis is sterility is rare. Important is sterility is not seen as a result of orchitis. Of course, you should always remember mumps is one infection which can also give rise to aseptic meningitis. Remember all this, and you also remember mumps is one infection which can give rise to aqueductal stenosis resulting in hydrocephalus in the brain, right? So these are few information about the mumps infection you should be knowing. Okay, now let us move on to the next question. A 1.5-month-old child presented to the emergency department with a respiratory rate of 65 per minute. The child was feeding well as per the parents. As per the ARI control program, how will you classify this pneumonia? So definitely 65 per minute is tachypnea for the 1.5-month-old child. We know this classification. Less than 2 months, the respiratory rate more than 60 per minute is tachypnea. For 2 to 12 months, the cutoff is anything more than 50 per minute, and for 12 months to 5 years, the cutoff is more than 40 per minute. So in this case, he is less than 2 months but is having a respiratory rate of 65 per minute. So definitely the child is having tachypnea. For children less than 2 months, the classification is somewhat different. Please remember this. So we go to the classification straight away. For children aged less than 2 months, there is nothing as pneumonia. There is either severe pneumonia or very severe disease. So this child straight away comes in the category of severe pneumonia. This will be the answer for you, right? Had this child been, let us say, at 3 months of age with this respiratory rate, then only this respiratory rate, and he is accepting feeds well, then I would classify the child as pneumonia. Please remember, there's a different classification for children who are less than 2 months and a different kind of classification for children who are more than 2 months of age. I would just like you to see that classification in a short while. Let us do another question and then we will see that classification. So a 2-year-old boy. So here we have a 2-year-old boy with cough, fever, difficulty in breathing, and very importantly, refusal to feed. His respiratory rate is 50 per minute. Definitely for a 2-year-old, 50 per minute is a tachypnea, but there is no chest indrawing. Auscultation of chest reveals bilateral creps. What is the next step you are going to do? First, let us classify this disease. Because the child is having refusal to feed, straight away he comes in either very severe disease, you call it, or you call it severe pneumonia. Both are one and the same thing. And for this, what we are going to do is, we are going to give first dose of IV antibiotic and refer the child to higher center. Okay, this is going to be the management of this child. Why? Because he is having one of the danger sign of IMNCI. So let us see what we were talking about. So as I was telling you, there's different classification for child aged less than 2 months, as was our first question, and different classification for 2 months to 5 years. Let us see the recent question. So in 2 months to 5 years, this child was unable to take the feeds or unable to drink is one and the same thing, and that is why he comes in either very severe disease or severe pneumonia, and refer the child urgently to the hospital and give first dose of appropriate antibiotic. That is your 2 months to 5 years classification. And if the child just had fast breathing or chest indrawing, then we just classify as pneumonia. If none of these, then we just classify as cough or cold. In pneumonia, we just give amoxi for 5 days and tell the child to come up after 3 days. In no cough or cold, we just follow up the child for 5 days. After 5 days, and we just advise the mother to give home care, and no antibiotic is allowed in this case, right? In children who are less than 2 months, either we have the very severe disease or severe pneumonia, and then we have the local bacterial infection in form of, let us say, umbilical sepsis in this case, or we have the severe disease or local infection, unlikely. So in this case, since the child was 1.5 months, there is no category of pneumonia or cough or cold in this category. There straight away that category is severe pneumonia. That is why I gave the diagnosis of severe pneumonia in that case. So deliberately I put the two questions so that you are able to understand, right? Okay, then during initial assessment of an unconscious pediatric patient, ABCD includes all of the following except. So airway, breathing, circulation, and D stands for what? D does not stand for dyspnea, definitely. D stands for something else. What is that something else? Let us see. So D stands for disability. Disability means you have to do a complete neurological examination of this child. In this case, in fact, it is A, B, C, D, E also nowadays according to the PALS classification. We will just see that in detail, right? So the answer correct over here is dyspnea. Dyspnea is an incorrect. For D stands for disability over here. That means a complete neurological examination has to be done. A child presented with severe vomiting and dehydration, A, B, C, D, E was performed. What does E stand for? So now let us, examine this in detail. So A stands for obviously maintaining a patent airway. So we have to see for the position of the head. We have to see whether there is a foreign body or not, or fluid or secretions are obstructing the airway or not, right? And what we have to do is we have to open the airway, suction the airway, and our goal is to attain a patent airway. B stands for looking and listening to the breath sounds, and respiratory rate and effort has to be assessed. Breath and added sounds have to be also seen. Subcutaneous emphysema also has to be assessed. And we have to also see whether there is any asymmetry of the trachea, deviation of the trachea is there or not, or there is presence of cyanosis. And then we have to act according to the SpO2. And we have to ensure there is sufficient oxygenation and ventilation. C stands for assessing the heart rate, right? Basically the cardiac activity. So heart rate, blood pressure, capillary refilling time, bleeding is there or not. And in this case, we have to establish the IV or the IU access, and we have to control the bleeding, and we have to resuscitate. We have to do the fluid resuscitation if the child has bled a lot, right? And the ultimate goal is stabilization of circulation. D, as I was telling you, that we have to look for the total neurological examination. That means D stands for disability, primarily in the neurological field. So that means we have to go for the GCS or the AVPU score, whatever is applicable to the child. We have to see the reactivity and the symmetry of the pupils, the blood glucose levels, and the basic neurological examination has to be carried out. And the goal is to evaluate the neurological state. Now, the question was, what does E stands for? E stands for exposing the child throughout and looking for any other marks of, let us say, injury or any other, features of the illness. Maybe we get to find some petechiae or, some kind of rash, which may give us the answer to what is the reason for the child's present condition. So that means a complete thorough skin examination of the child by exposing the complete body of the child has to be done. Very importantly, we have to recover the child, because we have to also think about the child might go into hypothermia. So that also has to be taken care of in exposure. Ultimately, the aim of the goal of this E is that we have to try and reveal other signs and symptoms that may be hidden under the clothes, that may give us some idea about the current present state of the child, right? So E stands for exposing the child and looking for injuries, edema, scars, petechiae, or some hemorrhages of the skin, right? So E stands for exposure. So E stands for exposure, right? Okay, then a 6-year-old child brought to the emergency department with fever, convulsions, increasing neck rigidity. On examination, there's pain on the passive knee extension. CSF examination shows reduced glucose, increased lymphocytes, and increased proteins. Formation of cobweb coagulum is there when CSF is standing for a while. You can see this cobweb coagulum over here, right? What is the most likely diagnosis? So very clearly you can see that the child is having some features of meningitis, and along with it, CSF examination reveals decreased increase glucose and very markedly increase protein, which is also, indicated by the formation of cobweb coagulum, straight away our diagnosis becomes tubercular meningitis, right? Okay, then let us move on to the next question. A child is brought to the emergency with GTCS. All of the following drugs can be used in the management except. So basically they are asking you which of the drugs are not used in managing the acute seizures, right? Acute onset of seizures is controlled by what all drugs? So we should know what all drugs are used for status epilepticus. We know lorazepam is used. We know midazolam is used. We know phenytoin is used. We can also go for valproate infusion. We can also go for levetiracetam. We know this, right? We can also go for phenobarbital, right? And apart from this, then finally, if nothing works, then we can induce coma, which is known as thiopental coma, right? So even that can be used, or ketamine also can be used. Can we use carbamazepine? No, we cannot use carbamazepine. So that is the odd man out over here. That is the correct option for this, question, right? Okay, next question is, so this is the complete, protocol of how to manage a child whose seizures are not getting controlled acutely. So all these drugs can be given, which we have already discussed. Which is the most common seizure found in the age group of less than 5 years? Straight away the answer is febrile seizures. Sometimes they have also given less than 2 years. Again, for the less than 2 years, the answer is going to be febrile seizures, the most common seizure disorder which we see in children less than 2 years of age, right? A 7-year-old girl comes with complaints of sudden cessation of motor activity or speech with a blank facial expression and flickering of the eyelids lasting for about 20 seconds. Drug of choice to treat this condition is. So this is nothing but a complete description of absence seizure. Yes, everybody knows this, and the drug of choice is valproate in this case, right? Okay. Now, what are the other drugs to be used in different type of seizures? So focal seizure, the preferred drug is the carbamazepine family. For GTCS, either we go for valproate is the first line and the phenytoin is the second line over here. Absence seizure, of course, valproate if it is given, we go for it. Otherwise, we can also go for lamotrigine. Epileptic spasms, or as we call it famously as infantile spasms, the drug of choice is ACTH followed by steroids. Myoclonic seizures, any kind of myoclonic seizures is controlled by valproate, and of course the tonic seizures are controlled by valproate and atonic also by valproate. Other alternative is lamotrigine in both the cases, right? Okay, now let us come to neural tube defects. One of the topics where I've been following every year, you get a question from neural tube defects. So you should be thorough with this topic very clearly. So neural tube defects, these are all the neural tube defects you should be aware of. In very recent FMGE, they had asked for craniorachiasis, which is the completely open brain and spinal cord. Then anencephaly, where there is lack of the brain tissue, only there is a rudimentary brain stem. Then we have encephalocele, where there is herniation of the brain along with the meninges. Then anencephaly, where we get to see retroflexion of the head along with encephalocele and craniorachias of the spine and the head. And then we have the spina bifida occulta, closed spinal dysraphism, or the lump in the lower part of the spinal cord, which can be just the herniation of the meninges along with the CSF, or there can be herniation along with the CSF and even the spinal cord. Then we call it meningomyelocele. When there is only herniation of CSF along with the meninges, we call it meningocele, right? Okay. So all the questions which have come in a newborn with the following presentation. So what is this? We know what are we looking at? We are looking with something known as either meningocele or a meningomyelocele, right? The mode of inheritance and the suspected embryological abnormality respectively is. We know neural tube defect is multifactorial in inheritance. So this is totally ruled out, right? Now, what is this? Is failure of anterior neuropore or failure of closure of posterior neuropore? So for this, we have to see the embryology of the neural tube defect. We should know this, that the neural tube defect, that arises from the failure of closure of the neural tube, right, in the 3rd or 4th week of in utero development. Now, there are two parts of this neural tube. One is the anterior part, right, and one is the posterior part. The anterior part is also known as the cranial neuropore. Remember this, right? And the posterior part is also known as the caudal neuropore, right? Right. Now, if we have to see this, so you can see that when there is a problem with the cranial neuropore, so we'll have defects like anencephaly, or we'll have defects like iniencephaly with the cranial neuropore. When there is problem with the failure of closure of the middle part of the neural tube, we'll have defects like craniorachisis or encephalocele. When there's a problem with the closure of the caudal neuropole, we'll have defects like spina bifida occulta, or we'll have defect like closed spina bifida occulta, or we will have defects like meningocele or myelomeningocele. The idea is that if a defect, neural tube defect, is in the lower portion of the spinal cord, then it is because of the failure of the closure of the caudal neuropore. If the neural tube defect is in the upper part of the spinal cord, let us say there is a meningocele in the cranial region, then we will call it failure of closure of the cranial neuropore, right? Now, let us go back to the question and see, here is a defect in the lower part of the spinal cord. So, our correct answer is going to be failure of closure of the caudal neuropore. Caudal neuropore is also known as the posterior neuropore, right? So, you can either write it caudal or you can call it posterior neuropore. Anterior neuropore is also known as cranial neuropore. So, please remember this. Any defects in the upper part of the spinal cord is because of the failure of the closure of cranial or the anterior neuropore. Any defect arising because arising in the lower part of the spinal cord is because of the failure of the closure of posterior or the caudal neuropore. I hope this is correct, right? This is clear to you. Now, let us diagnose all these kind of pics which come in your exam. So, this is craniorachisis. We know this. This is iniencephaly. How do you diagnose this? Extreme retroflexion of the head along with the encephalocele is there. This is straight away your encephalocele, right? And this is nothing but very, very commonly neural tube defect anencephaly, where you can see there is complete absence of the brain tissue, right? So, this is anencephaly and this is various type of neural tube defects for you. Other than this, you should also know how to prevent neural tube defects. You know the dose of 0.4 mg folic acid has to be started on all pregnant ladies, right? And if, for example, a lady has already delivered a child with neural tube defect, then in the next pregnancy, we start the folic acid 1 to 2 months before conception. Remember that, right? So, that has to be started only in those females who are pregnant for second time and already delivered a baby with neural tube defect. And the dose is also different. The dose is 4 times the dose, 4 mg or a 5 mg folic acid has to be given 1 to 2 months before conception, right? Okay. Then a child presents with Lisch nodules on iris and cafe au lait spots. We can see cafe au lait spots. We can see the Lisch nodules on the iris, which are nothing but hematomas. Similar symptoms are seen in his father and grandmother. What is the most common mode of transmission of this condition? So, these are neurofibromas and the mode of transmission is autosomal dominant. So, we should know about NF1 very clearly. NF1, we have the 7 criteria. We should know 2 out of 7 signs if present, they help in diagnosis. First is the presence of cafe au lait macules, right? Second criteria is axillary or inguinal freckling, right? Axillary or inguinal freckling. Then third criteria is 2 or more iris Lisch nodules, which are the hematomas. Fourth criteria is the 2 or more neurofibromas. Fifth criteria is the sphenoid dysplasia. And sixth criteria is optic glioma, which is the main CNS tumor. The question has also been asked on this. And the seventh criteria is a first degree relative with NF1 if exist. Relative with NF1, right? 2 out of 7 if present, they help us in the diagnosis of NF1, right? Next question, a 4-year-old child presents to you with difficulty in getting up from sitting position. On examination, his calves in both the legs are unduly prominent and there is similar history in his maternal uncle. All of the following statements about this condition is true except. So what are we dealing with? Yes, we are dealing with DMD. Is it a X-linked dominant disorder? No, this is X-linked recessive disorder. You are not supposed to forget the inheritance pattern of DMD. Why? Because DMD is one disease which is extensively studied in genetics, number one. Number two, the gene which is involved, or the mutated gene which is known as the dystrophin gene, is one of the largest genes to be studied till date. So you should know the genetics of DMD very well. It is an X-linked recessive disorder. These children are more prone to develop epilepsy as compared to general population. Very true. Serum CPK level is grossly elevated and the involved mutated gene dystrophin codes for a sarcolemmal protein. Hence, it is responsible for muscle weakness. So, what is incorrect is the inheritance pattern which is given. It is not X-linked dominant, it is X-linked recessive. That is why boys are commonly affected and girls are kind of saved from developing the clinical scenario of this condition, right? Okay, so these are the, this you can see a child with DMD. This is known as the Gower sign positive, the way he's trying to get up from squatting position, and this is just a sign of proximal myopathy. Remember, Gower sign is not exclusive to DMD. Another thing which you should be knowing is the undue prominence of the calf, undue prominence of the calf muscles, right? So even that, this occurs because of the, why does this occur? Calf pseudo hypertrophy. Why pseudo hypertrophy? Because the muscle fibers have already degenerated. They are replaced by fibro-fatty tissue, and which is responsible for the pseudo hypertrophy of the calf muscles, right? Okay, so this is how the disease progresses. You can see 2 years minimal symptoms, 8 years develops lumbar lordosis, weakness especially of the pelvic girdle muscles, and by 12 to 14 years catches hold of a wheelchair and then ensues severe crippling deformities and contractures, right? So this is how the disease progresses of Duchenne muscular dystrophy, right? Okay. Then, which type of cerebral palsy is seen commonly in neonates with kernicterus? We know kernicterus, basically which part of the brain is getting affected? Yes, you guessed it right. It is the basal ganglia. That is where the bilirubin will go and deposit it. And this bilirubin, remember, is unconjugated, highly toxic bilirubin. And this goes and gets deposited and results in the bilirubin encephalopathy, and because of that the child develops a cerebral palsy in which the child will be having chorioethetoid movements, because it is the basal ganglia that is getting affected, and because of the chorioethetoid movements the name given to cerebral palsy is dyskinetic cerebral palsy. So correct answer is going to be dyskinetic cerebral palsy. So it's very 2 and 2 together. Neurology works like that, right? You should be knowing this. Okay, then 7-year-old boy, so this is not spastic diplegia, this is dyskinetic cerebral palsy. That is the correct answer over here, right? Okay, 7-year-old boy presents to the pediatric OPD with chief complaints of rapid onset of puffiness around the eyes, pedal edema and cola-colored urine. You can see the cola-colored urine after he recovered from a sore throat 2 weeks back. All of the following statements are true except, right, regarding the probable diagnosis. So first tell me what is the diagnosis. Yes, you guessed it right. If you have a 2 weeks gap between the sore throat and the child coming up with cola-colored urine, my diagnosis straight away becomes PSGN, post-streptococcal glomerulonephritis. So, electron microscopy shows humps on the subepithelial side of the glandular basement membrane. Yes, very true. 90% of patients have low serum C3 levels which normalize within 8 to 12 weeks. This is also true. Usually occurs 1 to 4 weeks after an infection with group B beta hemolytic streptococci. The answer is, this is our answer, because this is false. It is not group B, it is group A beta hemolytic streptococci. Renal function substantially compromised for more than 7 to 10 days warrants a kidney biopsy, which is again very much true. So answer is, it is group A beta hemolytic streptococci. So C is the correct option over here. Now very importantly, you should know everything about PSGN, because PSGN, and another question they ask you is about nephrotic syndrome. PSGN, usually you will have a bigger age child, and usually in nephrotic syndrome, what the type of nephrotic syndrome what we see in children is minimal change disease that usually occurs in children who are less than 7 years. So when you have massive proteinuria occurring, call it nephrotic syndrome. When you have good amount of hematuria with minimal proteinuria, then call it nephritic syndrome. And the commonest variety of nephritic syndrome what we come across is PSG and post-streptococcal glomerulonephritis, right? Okay. A newborn with ambiguous genitalia and high 17-hydroxyprogesterone and DIA levels, which enzyme deficiency are we talking about? So when you have a very high 17 OHP levels, this is a marker for, we all know, 21 hydroxylase deficiency, which is the responsible for more than 90% cases of congenital adrenal hyperplasia. So what deficiency are we talking about is 21 hydroxylase deficiency, right? And we can see this from this flow chart also. If you want to have a look why 17 OHP levels are elevated, you know there's a block here, 21 OH is deficient. This is also block here, so you can see 17 OHP will be greatly. This will also be elevated, this will also be elevated, and the whole of this will go in the production of your this thing, DIA and androstenedione, which are your two sex steroids. So increased levels of sex steroids with increased levels of progesterone and 17 OHP points towards 21 hydroxylase deficiency. At least remember this much. This is the commonest enzyme deficiency resulting in CAH, right? And what we see in 21 OH deficiency is that in females, we get to see female pseudo hermaphrodite, right? While males at birth are normal, right? Later on, they may develop precocious puberty. So, but that is later on, right? Okay. A child of short stature is being evaluated. Growth hormone levels are shown to be high, but IGF-1 levels are shown to be low, which is the most likely diagnosis. So, when you have a low IGF-1 levels, what do we call it? We call it Laron syndrome. Now, problem is Laron syndrome is not given in the option. So, we will call it GH receptor defect, because we all know that IGF-1 is the receptor through which the growth hormone would act. So, this is the growth hormone receptor defect. So, what is Laron syndrome? Let us have a look. So, Laron syndrome, you know, for all that matter, is because of the low IGF-1 levels, and usually these children at birth, the birth height and weight are totally normal. Okay, they are totally normal, but with the passage of time, they start developing short stature, and very interestingly, you know, they totally resemble children with growth hormone deficiency. But interestingly, the growth hormone levels in these children, they are very high, and still they are short stature, right? They are still short stature, but the growth hormone levels are high, right? And this short stature is evident after the first year of age. In the first year, they are usually okay, but after first year of age, the short stature is very much evident. And this growth hormone levels, that is both resting and stimulated growth hormone levels, both growth hormone levels are high in this case. And what is diagnostic is when you go for the IGF-1 level, that is markedly low, and that is diagnostic for this condition, which is known as Laron syndrome. Many times asked in your exam, you should be prepared for it, right? Okay, then which of the following is not true about atrial septal defect? There is defect in the region of fossa ovalis. This is true. Blood flow from left atrium to right atrium. True. Increased blood flow through lungs leads to pulmonary plethora. Again, true. Splitting of first heart sound. So, this is false. There is splitting of the second heart sound is widely split and fixed, not the first heart sound. So, the correct answer is going to be the D option, right? Then, adolescent complains of intermittent claudication, dizziness and headache. Most likely cardiac lesion is. So, when the adolescent is complaining of this, then you should always think about coarctation of aorta, because in the adolescent age group, coarctation of aorta presents with hypertension and intermittent claudication. Why? Because the collateral supplying these lower periphery is not able to increase the blood supply when the demand increases. So they present with intermittent claudication. That is the reason. And most of the blood is being shunted in the upper arteries, resulting in hypertension. So there's disparity of the blood pressure between the upper limbs and the lower limbs, and the more blood pressure in the upper limbs results in the child developing headache, right? Okay. Then, cardiology, so the radiology of coarctation of aorta should be very clear with you. So this is the 3 sign which is visible on the over-penetrated chest X-ray film because of the coarctated segment. If you do a barium swallow, so on barium swallow, what you get to see as a E-shaped. Can you see this E-shaped indentation on the barium-filled esophagus of the coarctated segment of the aorta, right? Then this is the rib notching. If you can see the inferior portion of the ribs, it is notched, totally eroded. Why? Because of the intercostal arteries which become tortuous. And why they become tortuous? Because they are supplying the collaterals. And as the blood supply increases, they become tortuous, and this results in inferior rib notching. Remember, rib notching and the inferior border is not visible before 6 to 10 years of age. It is only visible after this time, number 1. Number 2, rib notching reverses or becomes okay. It reverses when the coarctation is corrected, right? So this should be clear. Remember, another thing, rib notching is more visible in the lower ribs, that is from 4th to 7th rib, right? Okay. Then child with cyanosis has the following chest X-ray, identify the diagnosis. So very clear-cut question. Can you see this? What is this? Yes, very good. You can call it snowman appearance, or you can call it figure of 8 appearance. And figure of 8 appearance is very classically seen with what? Yes, it is seen with supracardiac tap. We see it is also known as a snowman sign. So the correct option is the B option over here, right? Okay, then sometimes they can ask you what is this, egg on end appearance and a cyanotic heart disease. Then you will call it TGA, transposition of great arteries. Sometimes they may give you this, right? And they may ask you what is the diagnosis? Upturned apex of the heart. So this is a boot shaped heart. This is so classical of TOF, tetralogy of Fallot, right? Okay. So to memorize, please remember, if you don't want to, right now go into details of cyanotic heart disease, please remember this table. This table will help you solve many MCQs. So when you have a child who's having, let us say, pulmonary plethora, cyanosis with pulmonary plethora, so think of these diagnoses: TGA, TAP VC, HLHS. They are not going to ask you about DORV or truncus arteriosus. At least think of these 3 options. When you have pulmonary oligemia with cyanosis plus cyanosis, then you have to think of all these options, and especially when you have pulmonary oligemia with cardiomegaly, straight away the diagnosis becomes Epstein anomaly. Or then otherwise, if there is no cardiomegaly, then think of all these disorders except Epstein anomaly, right? So this is how you are going to approach a case of cyanotic heart disease if asked in your exam, right? Okay, now let us move forward. A child with wheat allergy can be given. They are talking about celiac sprue. You should be very clear what all to be avoided when there is wheat allergy. So you cannot give anything related to wheat. Suji is derived from wheat. Dalia is nothing but broken wheat. Remember this. Many children got this answer wrong last time because they didn't know that dalia actually is broken wheat. So even this cannot be given. Rice can very well be given. So that is the answer. What about oats? Now for oats, you have to be very, very careful. See, always remember, oats per se, if totally, uncontaminated, can be given. But usually in a manufacturing facility, oats get contaminated with wheat. And that is why even that cannot be given. So in this scenario, since you have a very soft option, a straight option over here, that is rice, which is totally allowed in celiac disease. So that can be given. But oats is very controversial. Please mark oats with caution. per se oats can be given if it is manufactured at a facility where the wheat contamination is not occurring, but it is usually a norm that oats get contaminated with wheat, so that is why we do not give oats. Per se oats can be given. So this points, this little information may help you solve future MCQs when you have this information in your head. If you have a very clear cut option rice, then you go straight away go for rice only over here, right? Okay, then these are gluten-free grains. Remember this one. What you have to remember is what cannot be given. BROW. We know B stands for barley, R stands for rye, O stands for oats. But this is very controversial. I've already told you. And W stands for wheat. Semolina is nothing but suji. It is very much given over here, right? So this cannot be given. Then what can be given is, you can see popcorn can be given, quinoa can be given, rice can be given, tapioca can be given, amaranth and arrowroot and besan can also be given, because besan is derived from the pulses, that is chane ki dal, right? So you should be knowing all this. So these cannot be given, right? Okay, the 3-year-old child weighing 15 kg is having loose stools and vomiting. He is lethargic, obtunded, not able to drink water, and the skin pinch goes slowly back. His eyes are very sunken, mouth and tongue is dry, and tears are absent. What is the best treatment plan for this child? See, first of all, we have to assess what is the level of dehydration in this child. Every year you get a question from this scenario. Pneumonia and diarrhea, you should be very thorough with. Definitely you will get a question. So this time, if you have seen the child is lethargic, obtunded, not able to drink water, definitely he comes in the category of severe dehydration. Now, how do we manage a severe dehydration? We know that in severe dehydration, we have to push in 100 ml per kg. And how do we push in 100 ml per kg? In two phases. First, 30 ml per kg has to be given, and then 70 ml per kg has to be given. 30 ml per kg has to be given in, let us say, 30 minutes, right? And 70 ml per kg has to be given in 2.5 hours. So total resuscitation time totally is 2.5 plus 30 minutes is 3 hours. This is for child who is more than 12 months of age. In 12 months of age, you give 30 minutes plus 2.5 hours. In less than 12 months of age, what you do is, again 30 ml per kg is given, but this is given over 1 hour, and the remaining is given over 4-5 hours. So resuscitation in a child who is of lesser age is done very slowly, over 6 hours. A child who is above 1 year of age, resuscitation can be done fast, that is within a span of 3 hours. This should be very clear. It is very important that you have to divide the fluid into 30 ml per kg and 70 ml per kg. So in this case, we know 15 kg is the weight of the child. So initially we will give 450 ml over what? Over 30 minutes. And then it should be followed by 15 kg into 70, which comes out to be 1050 ml over next 2.5 hours, right? So can you see any option which has both of these? Yes, this option is the B option, and this is the correct option. Rest all options are wrong options. We are not going to go this. Definitely the C option is wrong, because ORS anyways has no place for severe dehydration, right? Again, D option is wrong, because again we are giving ORS, and in A option they are giving straight away 1050 ml, that is 70 ml per kg over 6 hours. Again, not recommended. In severe dehydration, you have to push a total fluid of 100 ml per kg over either 3 hours or 6 hours, depending on the age of the child. Is that very clear? So hence we have solved this question. Then let us move forward. So this is how you assess the dehydration. We know this term, and severity of dehydration, we know either no, some or severe. In no dehydration, 50 ml per kg fluid has to be given, home-based treatment, and home-based fluid you can also give ORS, but home-based is also allowed. Some dehydration is we have to give around 75 ml per kg fluid, and this is a hospital-based treatment, but we have to give orally only, and what do we give is ORS in this case. And severe dehydration, we have to give IV, RL or NS can be given, and the dose is 100 ml per kg. We have already discussed it, right? Okay, then ORS, osmolarity and composition you should be aware of. Please go through this. And the treatment we have to, this is the plan A, plan B or plan C. So this is plan A, what we were talking about. This is plan B. For some dehydration, we follow the plan B. And for severe dehydration, we follow the plan C, which we have discussed, right? So this is it. Okay, then zinc supplementation, this is also asked in your previous years. So please remember, it is 10 mg for children who are less than 6 months of age, 10 mg per day, or 20 mg per day in children who are more than 6 months of age. So this is how you have to supplement the zinc. Has to be supplemented in both the cases orally only, right? Okay. A term newborn presents with frothing, excessive drooling and coughing with feeds. A chest x-ray done showed the following findings. So what do you see on the chest x-ray? Can you see the coiling of the tube? So straight away our diagnosis becomes tracheoesophageal fistula. Now tracheoesophageal fistula, what will happen in this case? Polyhydramnios may be present antenatally, very correct, because the child has difficulty in swallowing the amniotic fluid. So there will be more accumulation of the amniotic fluid in the uterine cavity. Then H-type fistula may come to clinical attention soon after birth. No, H-type fistula, it presents very late. It is not evident at the time of birth. So this is what is the incorrect statement they were saying. Then most common type is the type where upper esophagus ends in a blind pouch and the distal esophagus is connected to trachea. Yes, this is the type C variety, which is the most common type, and it is commonly associated with Bacterial type group of anomalies. Yes, very true. So our correct answer is the option B over here. Then, so this is the different types of variety, and the most common variety, as you were saying, is the C variety. This is the most common variety, and this you can see is the H-type fistula, which presents very late, right? Okay. Then, a term newborn born by vaginal delivery developed respiratory distress soon after birth. On examination, newborn had scaphoid abdomen, decreased breath sound on the left side of the chest. Chest x-ray of newborn is given below. All of the following regarding the illness is true except. So you can see the various air fluid levels are there in the chest, right? On the left side, what are we dealing with? Yes, we are dealing with congenital diaphragmatic hernia. Very true. The most common type is herniation through foramen of Bogdelic. Yes, this is the true statement. Oligohydramnios is a common association. Please remember, oligohydramnios will be seen with the renal disorders. Why renal disorders? Because we know that after 16th week of gestation, remember that after 16th week of gestation, it is the urine of the fetus which contributes maximally to the amniotic fluid. So whenever there are renal disorders, some congenital abnormalities of the renal system, then we get to see oligohydramnios. In this case, we'll get to see polyhydramnios because the child is not able to swallow the amniotic fluid in this congenital diaphragmatic hernia. So this is the, as I was telling you, so this is the incorrect option. B is the incorrect option. Let us see the other options also. All infants born with this condition should be intubated after birth. Of course, yes, we know that bag and mask ventilation is contraindicated in congenital diaphragmatic hernia. Degree of pulmonary hyperplasia is an important prognostic factor. Of course, this is the correct statement. So here the correct option is the option B, right? Okay, then a 5-week-old infant presents with non-bilious projectile vomiting, following which the child is hungry and ready to feed again. On examination, there is visible peristalsis and a lump is palpable in the mid-epigastrium area. Which of the following statement is correct? So first of all, what is the diagnosis? So when you have a 5-week-old infant presented with non-bilious projectile vomiting, first diagnosis should be hypertrophic pyloric stenosis, and then this is further substantiated by visible peristalsis, and the child is hungry and voracious, having a voracious appetite. That means there is nothing seriously systemically wrong with the child. There is no infection. The child is not vomiting because of any sepsis or anything, right? There is some organic obstruction over there, and that is what is causing the child to vomit, and then again he is hungry to eat more, right? And the visible peristalsis and lump in the mid-epigastrium area, which again tells you that this is idiopathic hypertrophic pyloric stenosis, right? Now, which of the following statement is correct? Hypochloremic in fact, this should be which of the following statement is incorrect? Is incorrect. That is the question over here. Now, hypochloremic metabolic alkalosis is a common finding. This is a correct statement. Ultrasound abdomen is confirmatory in this kind of illness. Lump is easily palpated just before vomiting. This is an incorrect statement. Remember this. This is the answer. Why? Because lump is easiest palpable just after the vomiting. So, after the vomiting, you can palpate the lump very clearly, right? Then incidence is more in males. This is also a correct option. So, therefore, the correct answer in this case is going to be the C. C is the correct answer. So, few words about hypertrophic pyloric stenosis you should be aware of. So, hypertrophic pyloric stenosis, you know, it is a disease which is the most common surgical disorder of, most common surgical cause of intestinal obstruction, right? And in this, what happens is that there is hypertrophy of the circular muscles. The question has come on this also. Whether the hypertrophy of the longitudinal muscles of the pylorus or the circular muscles, the answer is hypertrophy of the circular muscles, right? And it is most common, very common in infants having a blood group of either O or B. So, O or B blood group, and usually more commonly seen in males than females, very importantly. And there is occurs because of, some theories have been propagated, have been proposed that it occurs because of the decreased in the nitrous oxide production, or there is some abnormal enteric innervation which gives rise to this problem, right? Then, so we get to see this thickened pylorus. It gives rise to a olive-shaped mass, right? And that is visible as peristalsis, right? And usually the presentation occurs anywhere between 1 week to 5 months. The clinical classic presentation is around 5 weeks of age. Forceful projectile postprandial non-villous vomiting will be seen, and after vomiting the child is hungry, has a voracious appetite. Very important clue for you to make a diagnosis. And usually chronic vomiting lands the child with hypochloremic hypokalemic metabolic alkalosis. On examination, there's a visible peristalsis from left to right, and a mobile olive-shaped mass can be palpated, and feeding is useful for diagnosis as it increases the peristalsis and the palpation of the mass becomes easier. X-ray abdomen shows a single bubble sign. So, you can see a single bubble over here, right? And ultrasound is the most sensitive and specific. Why? Because if you see a pyloric thickness more than 4 millimeter, it is diagnostic. If the pyloric length is between 15 to 19 millimeter, it is again diagnostic of idiopathic hypertrophic pyloric stenosis. If the pyloric diameter is between 10 to 14 millimeter, this is again diagnostic of hypertrophic pyloric stenosis. So, therefore, this is most diagnosed. Now, contrast studies, if you do elongated pyloric channel, which is known as a string sign, right? So, that is again confirmatory of this. So, you can see this is a string sign over here. Bulge of pyloric muscle into the antrum, this is known as the shoulder sign. This is again diagnostic of pyloric stenosis. Or the parallel streaks of barium in narrow channel, this is referred to as double tract sign, right? This is also helps us in making a diagnosis of the hypertrophic pyloric stenosis. What we have to do is, we have to do a myotomy of this, that is, we have to cut the excessive muscular tissues so as to relieve the obstruction. So, that is what is done, right? Okay, then a 6-year-old child presents with purpuric rash on the extensor surface of lower limbs, which is associated with arthralgia and abdominal pain. Lab investigation done in this child will reveal all of the following except. So, first tell me what is the diagnosis. I know you know the diagnosis. This is nothing but IgA vasculitis. Very, very important. IgA vasculitis, also known as HSP. We all know this by the name of Henoch-Schönlein purpura, or HSP vasculitis, or IgA vasculitis, where this increased IgA in the serum, and this is usually what you get to see is a purpuric rash on the extensor surfaces, which is very much shown here, along with the pain abdomen and severe pain in the knee joints, typically involving the knee joints, right? So, what would not be seen in this case is the thrombocytopenia. The platelet count is totally normal in HSP. It has got nothing to do with the rash. What is seen is a palpable purpura, and urine examination reveals mild proteinuria and hematuria, and indirect immunofluorescence on kidney biopsy specimen will show deposits of IgA. No wonder the other name is IgA vasculitis, right? So, that is it about HSP. Then all of the following are true regarding the illness depicted in these pictures. Now, what are the illness depicted in these pictures? Let us see. So you can see there is a non-purulent kind of conjunctivitis. There is a rash over here, right, which is a polymorphous, non-vesicular, non-exudative rash, right? And you can see a strawberry tongue, which is the erythema of the mucosal surfaces. You can see edema of the hands and the feet, right? So and of course, along with this, usually these children have unilateral cervical lymphnopathy and mucosal involvement, which we have already seen in form of strawberry tongue, right? So this kind of constellation of signs and symptoms is seen in, yes, you guessed it right, Kawasaki disease. So this is Kawasaki disease for you. It is the commonest vasculitis seen in children. Yes, this is a correct statement. Thrombocytosis with periungual peeling is a characteristic feature. This is also correct. The basic lesion in this case is a large vessel vasculitis involving especially the coronary artery. This is a wrong statement. Why? Because this is a medium to small vessel vasculitis. Remember this, because even the coronary artery comes in the medium vessel, right, category. So definitely this involves the coronary artery. This is correct. But the first part of the sentence is incorrect. So that is why this is our answer in this case. Hydrops of gallbladder and reactivation of BCG scar is a common occurrence, right? So there's a small and medium vessel vasculitis, red dry lips, strawberry tongue, and complication is giant coronary artery aneurysms, one of the few reasons which can result in MI in children. Remember, MI in children, there are two reasons you should know. One is KD. KD is Kawasaki disease. Other is L-kappa. What is L-kappa? Anomalous origin of left coronary artery from pulmonary artery. These are two causes which can result in myocardial infarction in children. In KD, therefore, we have to start the anti-inflammatory therapy in form of first give IVIG and then follow it up with aspirin therapy, right? So that has to be given to, prevent the occurrence of this giant coronary artery aneurysms, right? Okay, then let us move forward. 8-year-old boy presents with abnormal movements of upper limbs, clumsiness, speech difficulty, and deterioration of school performance with the given eye findings. What is your diagnosis? So the diagnosis is Wilson's disease in this case. How? So what we get to see is the KF ring, right? So KF ring is visible over here, and as you can see the abnormal movements, usually these children, they present with dystonias, right? So dystonias along with KF rings, and you should know that KF rings are more visible when the child has a neurological presentation of Wilson. Now the question arises, why does Wilson occur? Wilson occurs because this is an autosomal recessive condition caused by mutation in the ATP7B gene. Everybody knows this, right? And it is an autosomal recessive condition in which there is defective transport of the copper. So therefore, there is abnormal storage of copper deposition in the liver, leading to hepatocellular injury, CNS dysfunction, and very importantly, hemolytic anemia, right? So this is all about Wilson you should be knowing. And KF ring is seen more in the neurological manifestation. However, younger children usually have hepatic manifestation in form of increased amount of jaundice, right? Jaundice, which is having very high bilirubin levels in a child more than 5 years of age, always suspect Wilson. While the older children, they present with the neurological presentation in which KF ring will be seen in more than 80 to 90% of the cases. Remember that, right? So hepatic copper is the single best predictive marker and is considered to be the gold standards. And it is said that if the hepatic copper is more than 2.5 microgram per kg of the liver weight, that is virtually, totally suggestive of the diagnosis of Wilson disease. How do you treat this disease? Foods with high copper content like organ meats, like liver, chocolates, nuts should be totally avoided. Administration of copper chelating agents like penicillamine or trientine can be used. Even ammonium tetramolybdate is therapy of choice in neurological Wilson disease, but it is not easily available in India. Zinc salts also, present with a very good opportunity. They serve as a very good chelating agents, and this adequate therapy, whatever you choose, you go for zinc salts or ammonium tetrathiomolybdate, or you go for trientine, or you go for penicillamine, has to be continued throughout life. Otherwise, the child will deteriorate, right? So that is it about Wilson disease. So that is it. We have already discussed this, right? Treatment we have discussed. Now, a 1-month-old child, female neonate, is brought by her mother for evaluation of hypotonia. The baby was born at term to an elderly gravid mother. She has dysmorphic facies, flat facies, a flattened nasal bridge, upward slanting palpebral fissure, epicanthal fold, short narrow palate with small teeth, furrowed and large protruding tongue, small and dysplastic ears, brachycephaly, flattened occiput, short broad hands with a transverse palmar crease. What is a probable syndromic diagnosis? I don't think you need my help at all. They're so very characteristic of Down syndrome, right? So they've typically nicely given in the question, how does a child with Down syndrome look like? Something like this, a flat facial profile. You can see a single palmar crease, and this was asked in the recent FMGE examination. There's an increased gap between the first and the second toe, right? Other features are the growth failure, mental retardation, flat back or flat occiput is there, right? Abnormal ears will be there. Then you have the slanting eyes, you have the annular pancreas would be there. Other than that, you have the sandal gap we have already discussed. Hypotonia is a very important feature. Then Hirschsprung's disease is very commonly associated with Down syndrome. Then the children, they have a very high tendency of developing congenital heart defects, and the commonest congenital heart defect seen in a child with Down syndrome is endocardial cushion defect. Very, very important. You should be knowing this, right? So these are all the features of Down syndrome which you should be knowing. One syndrome which you should be thoroughly knowing in this. Then identify this syndrome. So what are we seeing over here? What we are seeing over here is a rocker bottom feet, right? And what we are seeing apart from this is the closed fists. Can you see the closed fists? Fist means muthi bana rakhi hai with index finger overlapping the third finger and the fifth digit. The fifth digit is overlapping the fourth digit, and the second digit is overlapping the third digit. And this with the closed fist, and the child is having definitely microcephaly is there, and the child is also having micrognathia. And what you can see is the narrow hips with limited abduction, and this you can see is the rocker bottom feet. So apart from this, these children also have cardiac defects, very, very important, and the commonest cardiac defect is the VSD in this child. What are we talking about? Yes, the correct answer is the Edwards syndrome. Whenever you see the rocker bottom feet and this kind of scenario of the fingers, the second digit overlapping the third digit and the fifth digit overlapping the fourth digit, think about Edwards syndrome. Two things only you have to remember: rocker bottom feet and this kind of, digit orientation in the hands, right? Coming to the next syndrome. So a neonate is born with a small head, small eyes, sloping forehead and cleft lip and palate, post-axial polydactyly and bulbous nose. What is the diagnosis, right? So we have the options over here. Downs and Edward does not look like. Now we are stuck between Patau and Turner. For sure, you know what is Turner syndrome. So by exclusion, we know the diagnosis is Patau syndrome. But what is so very characteristic of Patau syndrome? Patau syndrome, what you will get to see is the bulbous nose. You will get to see cleft lip and palate. Very importantly, you will get to see polydactyly. You can see both in the upper and the lower limbs, you get to see post-axial polydactyly, and you will also get to see overlapping of fingers, which is referred to as clinodactyly. Cleft lip and palate, this is seen almost in 80 to 90% of the cases. Again, congenital heart defects are very, very common, and one of the commonest congenital heart defect, again in this case similar to Edwards syndrome, is the VSD. Then apart from that, these children also have renal defects, scalp defects, undescended testis, and 80% they die by 1 year of age. Remember this, right? So when you have a scenario like cleft lip palate with polydactyly, always think about Patau syndrome. Of course, there are other features also like microcephaly, and again there are problems with the genital defects, and the heart defect is also there, right? So this is Patau syndrome. Also, we also refer to as trisomy 13, while Edwards syndrome is also known as trisomy 18. Yes. Okay, coming to the next syndrome. So trisomy 13, this we have discussed, right? So this is how a child of Patau syndrome would look like. You can never forget once you see the figure of the child. So Turner syndrome, we know, just to quick recap of the Turner syndrome, we know that this wide carrying angle is there, there's short fourth metacarpal, the hairline is, the webbing of the neck will be there, the child will be of short stature and it is going to be a girl child because we know the chromosome complement is XO. Then we have the rudimentary ovaries or the streak ovaries. There's no menstruation and we have the brown spots or nevi all over. And then we have the commonest congenital heart defect in this case is bicuspid aortic valve. Always remember this. The commonest heart defect is bicuspid aortic valve. And the second commonest heart, this is the commonest heart defect. The second commonest heart defect is, of course, the coarctation of aorta. So that brings us to the end of this session. I've tried to include as many questions and, probable questions which can be asked in your exam. Study well, keep on MCQing, keep on revising again and again, and this is surely going to help you. And remember, you are always better than you think you are, right? You remember, you are always better than you think you are. And when you believe in yourself, anything is possible. So wishing the best of luck in your exam. Just 22 days more to go. All the best. My hearty, I really wish you from the bottom of my heart that you ace your exam well and make us feel proud. Thank you. This is Dr. Deepali Gupta signing off, your pediatrics faculty from Allen Next. Okay.